Hi everyone, my name is Rachel. I'm one of the PGY1 ambulatory care residents, and today I'm going to be talking to you guys about the management of chronic obstructive pulmonary disease, or better known as COPD. And these slides have been adapted from some of our previous residents, which include Shelby Cohen. Today we'll be going over some background knowledge on COPD. We'll look at the clinical manifestations and how we medically manage COPD, as well as looking at exacerbations. And then finally, we'll wrap it up with antibiotic do's and don'ts.
COPD is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, which is usually caused by significant exposure to noxious particles or gases. COPD is the third leading cause of death in the world as of 2020, and more than 3 million people have died of COPD in 2012. It is also the fourth leading cause of death in the United States. Some common risk factors, the first one people usually think about is tobacco smoking, which is a risk factor. However, there are additional ones, including environmental chemical exposures, such as things like biomass fuel, air pollution, as well as genetic factors. There is a hereditary deficiency of alpha-1 antitrypsin, or AATD, which can lead to a decline in lung function or increase the risk of COPD. Female sex also increases the risk of COPD, as well as having asthma may be a risk factor for the development of airflow limitation and COPD. So this slide reviews the mechanisms related to developing COPD. COPD is actually an umbrella term for both chronic bronchitis and emphysema. Patients with COPD may have one or both. The cycle starts by initial tissue irritation and destruction due to risk factors mentioned in the prior slide, like smoking. This then leads to inflammation, as seen on the left box. Inflammation leads to excess mucus production, which causes airway damage and constriction of the bronchioles, thus airway restriction, also called chronic bronchitis. This is the obstruction that is referred to in the name COPD. Next, airway restriction leads to lung parenchyma destruction, which is on the box on the right. This leads to decreased alveolar attachments and decreased elastic recoil, which is called emphysema. The decreased alveolar attachments causes a smaller total large surface area, and thus the lungs do not exchange oxygen as well compared to healthy lungs. Decreased elastic recoil leads to air trapping and difficulty inhaling and exhaling air as well. Although both COPD and asthma are both associated with chronic inflammation of the respiratory tract, there are differences in the inflammatory cells and mediators involved in these two diseases. COPD inflammation is neutrophil driven, which means it is resistant to anti-inflammatory effects of some medications like inhaled corticosteroids, which drives the treatment options for COPD compared to asthma, which we will talk about in detail later in this slide set. So this flowchart is from the GOLD Guidelines, which is the guidelines for COPD assessment and treatment. The etiology, starting at the top, explains some of those risk factors that we just went over, such as smoking. Most patients with COPD will have had some kind of exposure or have been a smoker, current smoker, or if not, exposed to some type of pollutant or other host factors. This will lead to things like impaired lung growth, accelerated decline in lung function, lung injury, and/or lung and systemic inflammation. This then leads to those physiological changes that we discussed on the prior slide, including airflow limitation, as well as things like emphysema and clinical manifestations, including symptoms, increases in exacerbations, and leading to other comorbidities. The clinical manifestations for COPD will be the things that you're looking for when assessing a patient, including symptoms like dyspnea, cough, sputum production, wheezing, and chest tightness. Patients will also be at risk for having COPD exacerbations and increased risk of morbidity and mortality. This chart from the GOLD guidelines goes over key indicators for considering a diagnosis of COPD. Ultimately, you will need to perform spirometry in order to confirm a diagnosis, but these factors give you a good idea of potentially whether or not the patient may have COPD. You should be asking your patients things to assess these different factors. For example, dyspnea, is it progressive over time? Is it worse with exercise? Is it persistent? Most notably in comparison to asthma and your potential other differential diagnoses, it's helpful to know these details in order to assess whether or not you should be performing spirometry. Some other things would be asking about the characteristics of their chronic cough, their sputum production, their history of lower respiratory tract infections, assessing for environmental and family histories, exposures to different risk factors, and other childhood factors that may put them at a higher risk of COPD and making that diagnosis more likely. One of the common symptoms for COPD is a chronic cough. However, there can be other causes, of course, that are not COPD, and these are some things listed here from the guidelines that you should take into consideration in your differential diagnosis when working with patients with a chronic cough, as it may not necessarily always be COPD. Here they list both intrathoracic and extrathoracic causes that may be leading to a chronic cough that are not necessarily COPD. In addition to that, here's a useful list of potential differential diagnoses of COPD. Most notably, one that is commonly compared is asthma compared to COPD. With COPD, it's more commonly having an onset in midlife, whereas asthma is earlier in life, often in childhood, although patients may present with asthma later in life, and patients with COPD and many risk factors may present earlier if they've had earlier exposure to these risk factors. COPD symptoms slowly progress over time, and they do not get better or worse and reverse in any way. It's a progressive disease, hence the acronym, whereas asthma vary widely from day to day due to different exposures, often having symptoms worse during different times of the day, especially at night or in early morning. Patients with asthma most commonly also have allergies, rhinitis, and/or eczema, and may have a family history of asthma, and may also have a coexistence of obesity. Whereas in COPD patients, you're more commonly looking for that history of tobacco smoking or other exposures to other types of smoke. However, it is possible to develop COPD without ever smoking or being exposed specifically to tobacco smoking. But if that is the case, it's important to look for some of those other risk factors that we reviewed. Some other diagnoses in your differential could include congestive heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse panbronchiolitis. So the method for specifically diagnosing COPD should be considered in any patient with complaints of dyspnea, chronic cough, or sputum production, a history of recurrent lower respiratory tract infections, or a history of exposure to risk factors for the disease. If you think that your patient may have COPD, the next step would be to perform a spirometry, which is required for diagnosis. Once symptoms and risk factors are evaluated and COPD is suspected, spirometry should be performed. Spirometry is non-invasive, however, it may be difficult for many of these patients given their airflow limitation. A spirometer example is pictured on this slide. It is a device that is calibrated according to age, sex, height, and race. It measures the level of airflow limitation, the main components being FVC, or forced vital capacity, and FEV1, which is forced expiratory volume in 1 second. When you conduct spirometry for your patient, you'll first enter their information as directed into the device. When the device is ready, the patient should inhale a deep breath, then exhale through the mouthpiece, which is the pictured white tube coming out from the device in the photo. The correct technique is to blow as hard, as fast as they can, and then continue exhaling until they can no longer, or the device tells them to stop. Most patients require coaching to perform this correctly, so be prepared to cheer them on and tell them to keep blowing until they can't anymore. The device will prompt multiple attempts and take the best attempt overall. Then the patient will receive bronchodilator, either 400 micrograms of Asaba, 160 micrograms of Asama, or the two combined. Give the patient time to inhale this treatment therapy, and then after, you can repeat the spirometry about 10 to 15 minutes after Asaba is given. And then the device will know that this is a post-bronchodilation test. The device, after the second test is done, will print out the results of both the pre and post test. A COPD diagnosis is then analyzed from this information and will be indicated from the FEV1 over FVC after bronchodilator, and that number should be less than 0.7 to confirm that the patient has COPD. If you've never seen spirometry performed before and you know that you will need to be performing this in your clinic setting in the future, I would highly suggest you look up some common videos on YouTube. There's a lot of great demonstrations from respiratory therapists and other healthcare professionals, give you a good idea of what this looks like and also how to coach a patient to do this correctly. If a patient does not do this correctly, then you won't be given the correct information to get a diagnosis. So as I mentioned, after you complete the spirometry test, it will print off information with the data collected. It will also print off this graph, which is a great visualization of the patient's lung function. As you can see on the left is a normal spirometry result. And you can see that the patient here was able to exhale a large amount of volume in the initial first second, and they were able to exhale the full capacity of their lungs pretty early on, and then it plateaued around 2.5 seconds. However, in the spirometry results on the right showing obstructive disease, the patient is not able to exhale a large amount of volume in the first second, and it also takes them much longer to reach their full capacity exhaled at about 4 or 5 seconds. As you can see as well, their total volume capacity is much smaller at 3.2 liters compared to the 5 liters of the normal spirometry. Another COPD characteristic that is not as well represented on this slide, but we will go over in class, is the time spent exhaling the total air in the lungs. Remember that COPD patients have airway restriction and are not as easily able to exhale the air in their lungs. Thus, you will see the plateaued line continue much longer compared to someone without COPD who is able to exhale completely faster. So now we went over the diagnosis, which is the FEV1 over FVC of less than 0.7. Next, you will also use the spirometry results of the FEV1% predicted to classify the severity of airflow limitation in your patient. And in the GOLD guidelines, they give a great graph listed here of the different severity scores. So as you can see, if your patient has an FEV1 of greater than or equal to 80% predicted, then they would have a mild airflow limitation. However, if your patient has an FEV1 of, for example, 20% predicted, then they have a very severe airflow limitation. This is a good way to compare the severity of COPD in your patient compared to others. Remember that this FEV1 score is a percentage compared to normal volume for a person of the same gender, height, and age. So once your patient has an official diagnosis of COPD, you can use two different scoring tools to assess symptoms. The first is a COPD assessment test, or CAT, and then the next is the Modified Medical Research Council, or MMRC. Both of these scoring tools will be very important to continue to assess your patient and how well their COPD is managed. The CAT test looks at the impact of disease and burdens of daily symptoms and is scored from 0 to 40. And the MMRC looks at the baseline symptoms due to respiratory disease and scores from 0 to 4. Here's an example of a CAT assessment. These are things that you can either have the patient fill out in the waiting room before you see them for your office visit, or have them fill it out or go through it with them while you are interviewing them and assessing them for their COPD in clinic. For example, you can ask a patient on a scale of 0 to 5, 0 being I never cough and 5 being I cough all the time, how would you score yourself? And kind of go through the list and then add up the total score to get your final results for the CAT. The MMRC dyspnea scale is a lot shorter and can also be filled out prior to coming into the clinic visit and is given as a grade. So the patient may be able to assess this themselves, or during your interview after asking them questions, you can also grade them on this scale as well. Grade 4 is indicating a patient is too breathless to leave the house or breathless when dressing or undressing, and then the severity score decreases based on how far the patient can walk or keep up with people of the same age, or get short of breath when walking up on a level or walking up a slight hill, or if they only just get breathless with strenuous exercise. Next, we'll go into medication management and the different types of therapies available to patients with COPD.
Once your patient is diagnosed with COPD, you can use this assessment tool. So looking from the left to the right, we'll start by confirming the diagnosis of COPD by having an FEV1 to FVC ratio less than 0.7 post-bronchodilator. Then we'll assess their airflow limitation by giving them a gold grade based on their FEV1. And then finally, we'll make treatment decisions based on their exacerbation history and symptoms. If you're familiar with the chart on the bottom left, you'll probably notice that it looks a little different. So in the newly updated 2023 GOLD guidelines, they combined what was previously category C and D to create a new category, which is E. So you'll get the same treatment if you've had at least 2 moderate exacerbations or at least 1 exacerbation that led to a hospitalization, regardless of the severity of your symptoms, which we measure by that MMRC and CAT score.
So the reason why it's important to identify which A, B, C, or D group the patient is in is to know what initial treatment would be appropriate for the patient. If the patient is identified to be in group A because they don't have very severe symptoms using those symptom tools and they don't have a severe history of exacerbations, then it's appropriate to start the patient on just a bronchodilator and no other inhaler therapies. If the patient is identified in group B, then it would be appropriate to start either a LABA or LAMA inhaler, which we'll go into more detail in the next coming slides. If the patient does not have very severe symptoms, but they do have a strong history of exacerbations, then it would be appropriate to start on a LAMA inhaler specifically, as LAMA inhalers have more benefit in COPD compared to LABA inhalers, and we'll discuss more of that as well. And then lastly, if you have a patient who is initially diagnosed and their symptoms are very severe and also have a severe history of exacerbations, then it would be appropriate to start them on either a LAMA, could consider combination therapy with a LAMA and LABA inhaler, or consider ICS with a LABA, only if indicated for patients that have eosinophil count greater than or equal to 300. Also, the guidelines note that combination therapy with a LAMA and LABA inhaler is considered if the patient is highly symptomatic, such as having a CAT score of greater than 20. The GOLD guidelines also give a follow-up pharmacological treatment flow sheet that should be used to adjust therapy for COPD patients that have already been diagnosed. As you can see, it's based on the predominant symptom of either dyspnea or exacerbations. These recommendations do not depend on which ABCD assessment was made at diagnosis and can be used to adjust therapy or even de-escalate therapy if needed. For example, if a patient has predominantly dyspnea symptoms, they are very short of breath, and it's interfering with their activities of daily living, they are already on one LABA inhaler or LAMA inhaler, then this flow sheet would indicate that the patient should be escalated to combination therapy of a LABA-LAMA. As you can see here as well in the asterisks at the bottom, you can consider ICS therapy if a patient has an eosinophil count of greater than or equal to 300 or greater than or equal to 100 and 2 or more moderate exacerbations or 1 hospitalization. The reason why there are specific recommendations we'll go into more detail when we talk about ICS therapy in the following slides, but essentially ICS therapy has risks as well, so it's not blanket recommended for all patients as an option for escalation. It's also important to consider, as the flow sheet mentions here, is making sure that the patient is using their inhaler device correctly. If they potentially are having difficulties, even after educating them on how to use it, it could be considered to switch to an alternative inhaler with a different method that may be easier for the patient to use. Also should be investigating and treating other causes that may be giving the patient dyspnea. Alternatively, on the right, for exacerbations, patient would be increased from just one LABA or LAMA inhaler to a combination, and then assessing their eosinophil counts to consider ICS therapy. After all of this is used and the patient is still having exacerbations, you could consider roflumilast or azithromycin in former smokers, and we'll go into this in more detail when we talk about these medications in the upcoming slides. Now we'll be going through the different types of medication classes. The first one I wanted to talk about is long-acting muscarinic antagonists, or LAMAs. These work by blocking the bronchoconstrictor effects of acetylcholine on the M3 muscarinic receptors, which are expressed in airway smooth muscles, and this leads to a bronchodilator effect. Some of these last 24 hours, so they only need to be given once a day, whereas others last only 12 hours and would need to be given twice a day. The once-a-day options include tiotropium, called Spiriva, comes as a HandiHaler or a Respimat, Ameclidinium, which comes as Incruse Ellipta, Revefenacin, which comes as Yupelri, a nebulizer, and then the twice-a-day options include Aclidinium, which comes as 2-Dorza Press Air, and Glycopyrrolate, which comes as a Seebri Neohaler, and Loanhala, which comes as a nebulizer. As you can see here, there's lots of different types of inhaler forms, so it's important to consider what forms your patient may be comfortable using, maybe a little bit easier for them to use one over the other, and also if they've used any in a different type of inhaler in the past. Also would consider what type of insurance they have and whether or not their formulary requires a specific type of inhaler, as sometimes they may require something preferred one over the other. Otherwise, these work equally as well. It just depends on whether or not the patient is able to use them correctly to get the benefit of the medication. Some side effects that would come from this medication would be things like dryness in the mouth. Patients may also report a bitter or metallic taste. These are poorly absorbed when they're inhaled, so we don't really see any systemic anticholinergic effects. Also, I won't be going through how to use these inhalers during this slideshow, as we'll be bringing demos to class and going over that with you in person. But definitely, if you aren't familiar or haven't seen these before, it can be helpful to look online at some YouTube demonstrations or on the inhaler websites just to get familiar with how these different inhaler types work. The next class is called LABAs, or long-acting beta agonists. And the way I think about this is if you're familiar with SABAs, or short-acting beta agonists like albuterol, it's a common one that people think about as a rescue inhaler. Well, these are essentially the inhalers that last over a longer period of time throughout the day. Their specific mechanism is they're a B2 agonist, which essentially relaxes the airway smooth muscles by stimulating the beta-2 adrenergic receptors. This then leads to an increase in cyclic AMP and produces functional antagonism, which blocks bronchoconstriction. So essentially helping to open the airways to make it a little bit easier to breathe. Compared to SABA inhalers like albuterol, which usually wear off within 4 to 6 hours, these can last 12 to 24 hours. Similar to LAMAs, the dosing is based off of how long they last. Once daily inhalers include indacterol or Arcapta Neohaler, olodaterol or Striverity Respimat, vilanterol Ellipta, which is only in combination with imeclidinium as Anoro or fluticasone as Breo. And then twice daily inhalers include salmeterol or the Severant Discus, formoterol or Performist nebulizer, and aformoterol or Brovana nebulizer. Since these can stimulate the receptors, they can cause some tachycardia in patients, and they may be observing this or they may not really notice that at all. So as you can recall, in the stepwise increase in therapy from the guidelines, after a patient has been on either a LABA or LAMA inhaler, or if they have significant symptoms, then it may be appropriate to increase them to a combination therapy. The nice part about this is it comes in one inhaler, whereas the patient wouldn't have to use 2 different inhalers at one time. LAMA-LABA combinations come as umeclidinium and vilanterol, which is called Anoro Ellipta, tiotropium and olodaterol, which comes as Stiolto Respimat, indacterol with glycopyrrolate, which comes as Itrabron Neohaler, and aclidinium with formoterol, which comes as Daclear Press Air, and glycopyrrolate with formoterol, which comes as Bevepsi Aerosphere. It's important to consider too, as I already mentioned, what types of inhalers patients have already used before. So when possible, if they already feel comfortable, for example, with using the Respimat for Spiriva, then it would be more appropriate, if possible, to advance them to the Stiolto Respimat if you're increasing it to a combination therapy. However, if that's not an option based on cost, insurance, or other reasons, it's still appropriate to use any of these options as a combination therapy if needed. We also have SAMA and SABA combination inhalers, which includes ipratropium with albuterol, which is called Combivent Respimat inhaler, and then ipratropium with albuterol as a duo nebulizer. Inhaled corticosteroids, or ICS, provide anti-inflammatory effects on the airways. These may be considered in some cases for COPD patients that continue to have exacerbations and a lot of symptoms despite being on LABA-LAMA therapy, as we discussed earlier. However, ICS therapy is not routinely recommended for all COPD patients, and this is mainly due to an increased risk of pneumonia, which has been confirmed even at low doses of ICS therapy. This risk is higher in certain patient populations, including current smokers, those over 55 years old, those with a BMI of less than 25, or patients with a history of exacerbations or a history of pneumonia. Patients that have those risk factors should be considered use of ICS a little bit more cautiously, if not completely indicated. When ICS therapy is indicated, ICS combination with a LABA inhaler is more effective than either component alone in improving lung function and reducing exacerbations, but it does not have any difference in mortality outcomes for COPD. So when should you use ICS therapy? I know we talked about this a little bit earlier, but just to revisit that, it should be considered in patients that have greater than or equal to 2 exacerbations of COPD per year and an eosinophil count of greater than 300. Also would benefit patients that also have a history of asthma, as ICS therapy is a mainstay of treatment for asthma. And patients may have both asthma and COPD. You may consider ICS therapy in patients that have 1 moderate exacerbation of COPD in a year and or eosinophil counts of intermediate range of 100 to 300. However, you should not be using ICS therapy if patients have an eosinophil count less than 100 or if they've had repeated pneumonia events or any history of mycobacterial infection. Some other side effects other than that pneumonia risk from ICS therapy include oral candidiasis and a hoarse voice. An important counseling point for any inhaler that includes ICS is the patient must rinse and spit after taking the inhaler to prevent that oral thrush side effect. A good tip I like to tell patients if they're forgetting to do this is to try to take their inhaler right before they brush their teeth, either depending on, most of these are twice a day, so it works out pretty well, brushing your teeth in the morning at night. And then if they brush their teeth right after, then they should be fine. Otherwise, if they're out and about and they don't have access to that, they can still just rinse their mouth and gargle and spit, and that should be adequate. So as you can see here, I've listed the ICS monotherapy inhalers and the ICS combination inhalers with a LABA. It's important to note again that ICS therapy should never be used alone in COPD because of that risk of pneumonia, and there really is not benefit or indication to be using just an ICS inhaler for COPD patients. For ICS inhalers alone, you could consider using these if a patient is already using a LABA or LAMA inhaler and you just want to add it on, depending on what the patient's preference is or cost, things like that. ICS inhalers listed here are fluticasone, which comes as Flovent aerosol or discus, and Arnuity ellipta. Arnuity is the only one that is actually once daily, otherwise the rest are twice a day. Beclomethasone comes as Qvar aerosol. Budesonide comes as Pulmicort, which is a dry powder or a nebulizer, and mometasone, which comes as Asmanex dry powder. For combinations of ICS with LABA, all of these are twice a day dosing except for the Breo ellipta inhaler. Fluticasone with salmeterol comes as Advair aerosol or discus dry powder and HFA inhaler, and also as the AirDuo Respaclick. Fluticasone with vilanterol comes as the Breo dry powder ellipta, and budesonide with formoterol comes as Symbicort aerosol, and mometasone with formoterol comes as Dulera aerosol. Advair as fluticasone with salmeterol recently became available as generic called Wixela, which is cheaper but still pricey at around $100 compared to $300 for the brand. However, AirDuo Respaclick more recently also became generic and is available for $38 at CVS using a GoodRx coupon. So this is a great option for patients that otherwise would not be able to afford these inhalers due to cost. Lastly, we have triple therapy inhalers, or inhalers that have a combination of a LABA, LAMA, and ICS therapy. We have 2 different options. The first one that came out on the market is called Trelegy ellipta, which is a dry powder inhaler, and this includes the LABA vilanterol, the LAMA umeclidinium, and the ICS fluticasone. And then more recently on the market is Breztri Aerosphere, which is a metered dose inhaler, and the LABA is formoterol, LAMA is glycopyrrolate, and the ICS is budesonide. Triple therapy has been shown to improve lung function, patient-reported outcomes, and reduce exacerbations when compared to LAMA, LABA-LAMA combinations, and ICS-LABA combinations. Newer data in 2021 that was recently added to the GOLD guidelines now also show that triple therapy may have a beneficial effect on mortality in symptomatic patients with a history of frequent and/or severe exacerbations. Despite this, we still need more data to clearly show whether or not there's a benefit on mortality. However, it's important to consider triple therapy when indicated in patients that are still having exacerbations or symptoms despite being on a LABA-LAMA therapy. Also important to consider, again, that if a patient is on a prior combination therapy or different types of LABA-LAMA inhalers, you don't have to switch them to one of these that has the same ingredients, as it's still effective. So for example, if they're on a different type of inhaler combination LABA-LAMA, it's okay if the LABA is not vilanterol and the LAMA is not umeclidinium. So just increasing patients to triple therapy when indicated. And then if patients are improving and they're no longer having exacerbations or symptoms, because of that risk of having an ICS therapy increasing risk of pneumonia, may be considered to step down the therapy back to just a combination without the inhaled corticosteroids when indicated.
One of the ways that we can advocate for our patients and provide the best care possible is to use evidence-based approaches. So here are some of the pharmacologic and the non-pharmacologic strategies in COPD management proven to reduce mortality. Evidence has recently emerged from two large randomized control trials, the IMPACT and the ETHOS trials, and they showed that fixed dose inhaled triple therapy combos, so LABA, LAMA, ICS, reduced all-cause mortality when compared to dual inhaled long-acting bronchodilators. These trials were enriched for symptomatic patients with a history of frequent and/or severe exacerbations.
So this is another great slide from the GOLD guidelines that just reiterates what I had previously said on the slide, reviewing ICS therapies and when to consider adding on an ICS therapy for COPD patients. And mostly the biggest factors are whether or not they've had increased exacerbations, are uncontrolled, what their blood eosinophil count is, and whether or not they have in addition to COPD, also having asthma. Also important to note that prior to increasing any type of therapy, as I have mentioned before, is to make sure your patients are using their inhalers properly, because they may not be using it properly and thus having persistent symptoms or exacerbations, when in reality they just need to have a little bit more counseling or assistance in how to use the inhaler rather than stepping up the therapy. So that should be something that's assessed at each step before you increase your therapy for these patients. Back to this follow-up treatment algorithm, now that we've talked about the different types of inhalers, LABAs, LAMAs, and ICS therapy, you can see on the right with exacerbations, there's also these other medications that can be considered after you have exhausted the inhaler options. So we'll be talking about that on the next slide. These other therapies are listed here on this slide, the first being roflumilast. This is a PDE4 inhibitor and can be considered after triple therapy if FEV1 is less than 50% and the patient has chronic bronchitis. This may decrease the number of sputum neutrophils and eosinophils and would be a good therapy choice for patients that have a predominant chronic bronchitis subtype and a chronic productive cough. Unfortunately, it's often limited by its side effects, which include weight loss, sleep disorders, headaches, diarrhea, and nausea. The next is azithromycin at 250 milligrams a day or 500 milligrams 3 times a week, or erythromycin at 500 milligrams 2 times per day. And this would be used over 1 year and has been shown to reduce the risk of exacerbations compared to usual care. This is only recommended for patients that are non-smokers due to a post hoc analysis that suggested lesser benefit in active smokers. Unfortunately, this has been shown that azithromycin use was associated with an increased incidence of bacterial resistance and impaired hearing tests, so something to consider when weighing the benefits over the risks for using this therapy for a year. Next is these mucolytic and antioxidant agents, including erdocystine, carbocystine, and N-acetylcysteine. These are available over the counter and can be useful in reducing the risk of exacerbations, mainly in patients that have a lot of sputum production, by helping to break up that phlegm and make it a little bit easier for patients to get rid of that phlegm and also breathe easier. In COPD patients that are not receiving inhaled corticosteroids, these therapies have been shown to reduce exacerbations and modestly improve health status. Next is aminoafilin and theophylline. These are mexylanthonines. Theophylline has a small bronchodilator effect in stable COPD that can cause modest symptom benefit. However, theophylline is no longer recommended due to its side effect profile, and although it may improve FEV1, it has contradictory evidence for reducing exacerbations and is not recommended. And lastly, for patients that do have a documented alpha-1 antitrypsin deficiency, as mentioned in the beginning of this slideshow, with that hereditary factor, it may be beneficial for those patients to receive specific therapy for that deficiency. So after a patient has been initiated on COPD therapy, then it's important to follow up and reevaluate their current therapy. Reevaluation would include assessing their symptoms, exacerbation histories, whether or not they're using the inhaler appropriately based on how often they're using it, how many inhalations, and the actual way that they're using the inhaler, whether or not they're inhaling appropriately or preparing the inhaler, priming it, etc. You may consider escalation, de-escalation, and changing any inhalers a patient is on depending on your assessment during follow-up. The GOLD guidelines give a great overview of the management of COPD, starting from diagnosis, looking at symptoms, risk factors, and then performing the spirometry to confirm diagnosis, as we discussed, and then going into the initial assessment of that chart with the GOLD assessment of how severe their airflow limitation is based on the FEV1, as well as the ABCD chart based on symptoms and exacerbation history, as well as considering assessment for alpha-1 antitrypsin, assessing their smoking status and comorbidities. And then initial management, although we're also following ABCD, there's other things to consider, such as, of course, providing smoking cessation assistance, providing them the correct vaccinations if indicated, active lifestyle and exercise to improve symptoms, and self-management education, including understanding what their risk factors are, inhaler technique, what breathlessness management would be, and a written action plan, and then managing any additional comorbidities. At follow-ups, you would be reviewing symptoms, exacerbations, their smoking status, exposure to risk factors, inhaler technique, and the others listed here that we already reviewed. Patients may also need their pharmacotherapy adjusted, as well as non-pharmacological therapy options discussed. The overall goal for your patients would be to reduce their symptoms and then reduce the risk of progressing in their COPD. It's important to remember that COPD is not something that you can cure, but it's something that you can manage and prevent further progression, which is really important for quality of life, morbidity, and mortality. For symptoms, it's important to be able to relieve symptoms, improve patients' exercise tolerance, and thus help improve their overall health status. And then reducing their risk would be to prevent disease progression, prevent and treat any exacerbations, and reducing mortality. As mentioned, the GOLD guidelines do give recommendations for vaccinations for COPD patients. This goes into a little bit more detail about that. For influenza vaccinations, it can reduce serious illness and death and is recommended for all patients. The WHO and CDC recommend the COVID-19 vaccination for people with COPD, as well as the PPSV23 pneumococcal vaccine, which has been shown to reduce the incidence of community-acquired pneumonia in COPD patients that are less than 65, with an FEV1 of less than 40% predicted, and in those with comorbidities. In the general population, greater than or equal to 65 years old, the PCV13 has shown significant efficacy in reducing bacteremia and serious invasive pneumococcal disease. The new ACIP recommendations for the PCV13 vaccine has changed, and the decision is now based on clinical judgment and a discussion with the patient. So the GOLD guidelines are essentially agreeing with that recommendation and giving evidence as to when it may be beneficial for patients who may be at higher risk. The CDC recommends Tdap vaccination to prevent against pertussis for adults with COPD who were not vaccinated in their adolescence, and zoster vaccine to prevent against shingles once COPD patients reach the age of 50 or older, similar to the recommendations for the general public. So not much is new here, but just a good reminder as to the benefits of these vaccinations, as well as making sure that you're screening for things like this when you are seeing a patient for the first time, as well as follow-ups if it hasn't been addressed previously.
This chart goes over what factors you should consider whenever you're choosing an inhalation device. I won't read directly off the slide because in class we will be doing a hands-on inhaler demo practice session. So make sure to read over this slide and all the other ones and come with any questions you might have about inhalation techniques.
The last topic I wanted to touch on is COPD exacerbations. This is important to know because you may need to differentiate whether a patient is having an exacerbation, as well as if they're appropriate for outpatient or inpatient therapy. Symptoms of an exacerbation include increased dyspnea, increased sputum purulence and volume, increased cough and wheezing. Differential diagnoses include pneumonia, pneumothorax, pleural effusion, pulmonary embolism, congestive heart failure, and cardiac arrhythmia. Frequent exacerbations of greater than 2 times per year increase morbidity for COPD patients, so it's important to be following as much as we can evidence-based guidelines and therapies like we've discussed to help reduce the risk of exacerbations. The causes of exacerbations most frequently are due to a viral upper respiratory tract infection and can also be caused by different types of bacterial infections. The goal of exacerbation treatment is to reduce the negative impact of the current exacerbation and then prevent future exacerbations. More than 80% of exacerbations are managed in the outpatient setting. And depending on the severity of the exacerbation and other patient-specific factors and circumstances, hospitalization may be indicated, such as for patients who have frequent exacerbations, significant comorbid conditions, or they can't be managed as easily in the outpatient setting. A worsening of clinical status, including the development of new physical signs or pronounced increase in symptom intensity, may also warrant hospitalization or at least a visit to the emergency room for consideration of admission. Treatments for outpatient management include SABA/SAMA therapy, steroids, and antibiotics. For all patients, they should receive high doses of SABA plus or minus SAMA, and this will benefit them more immediately than their maintenance inhalers. And given that their maintenance inhalers like a LAMA or LABA act in a similar way, they may increase the risk of side effects when used together with the high doses of the short-acting therapies. So this is something that just depends on patient-specific factors and whether or not you'd want them to continue their maintenance inhalers or resume them after the high doses of the SABA therapy is complete. However, it should be resumed as soon as possible so that patients continue to receive benefit from managing their day-to-day symptoms and preventing any further exacerbations or disease progression. Corticosteroids can improve lung function, oxygenation, and shorten recovery time and hospitalization duration if a patient is admitted. Corticosteroids can be considered for patients that are experiencing an exacerbation, and the typical dose recommended is prednisone 40 milligrams daily or equivalent for no more than 5 to 7 days. This duration of therapy is based on systematic reviews that found extending the duration to up to 14 days did not provide any additional benefit, and this way patients have less of an exposure to steroids with this shorter duration of therapy. And lastly, antibiotics can shorten recovery time, reduce risk of early relapse, treatment failure, and hospitalization duration. The duration of therapy for antibiotics should also not be more than 5 to 7 days and should be considered for patients if they're having increased dyspnea, sputum volume, and sputum purulence, or can be considered if a patient has sputum purulence and one other symptom. For antibiotic drug selection, you should be targeting typical respiratory pathogens that you're anticipating, as well as considering any local resistance patterns.
One topic that I don't think we talk about enough is the appropriate use of antibiotics in a COPD exacerbation. The clinical picture can be blurred because a lot of the times it might look like pneumonia, it might also look like a COPD exacerbation, or it could even be a viral cause of the infection. So the cardinal rule I want you all to remember is that antibiotics should be given to patients who experience 3 of the cardinal symptoms. If they have increased dyspnea, so they have increased work of breath, they have increased sputum volume, or increased sputum purulence. The exception to this rule is that you only need 2 of these cardinal symptoms if increased purulence is one of your symptoms. Also, if the patients are critically ill or they're mechanically ventilated, they're going to need antibiotics as well. And data has shown that short courses, so durations of therapy such as 3 to 5 days, have the same efficacy as longer durations do.
One really useful thing to provide patients is a COPD action plan for how to manage exacerbations when they occur. Oftentimes, patients may have exacerbations and may not seek out care right away. So it's important for patients to understand what type of symptoms to look out for and whether or not that might be an exacerbation that warrants treatment. So as you can see here, this is just an example I took from online. There's lots of different action plan templates that you can use depending on what your preference is, but you would help fill this out for the patient when you see them for either an initial or follow-up visit and go through the different zones. So green zone is their symptoms are managed well, they're not having any complaints, they continue to take their maintenance inhalers daily. In the yellow zone, they're experiencing some of those exacerbation symptoms, and this is where you would counsel them on what to do, whether or not to continue their daily medications, to use quick reliever inhalers like a SABA, like their albuterol, and for how many hours, as well as giving them a prescription for prednisone that they can fill if they are experiencing an exacerbation, and potentially an antibiotic if they're at high risk for exacerbations and you anticipate them needing an antibiotic. But it's important to be able to counsel patients on when it's appropriate to use these things and whether or not they should start that. If they do go into the yellow zone, they should be contacting their provider to let them know so that any follow-up can be arranged. But this way, this helps to avoid any delays in care, since starting things like the steroid can help manage the exacerbation rather than delaying the care over multiple days. And then the red zone would go over some more severe symptoms where a patient would need immediate medical attention and likely hospitalization due to a more severe exacerbation. The majority of this presentation was referencing the GOLD guidelines for COPD. I have listed some other guidelines available for your reference here that may be useful when you're looking at some more of those gray areas in the management of COPD. I also wanted to mention as well that the GOLD Guidelines website is really useful. A lot of the handouts or charts that I provided in the slideshow were directly from the guidelines, and you're able to access this freely to anybody who wants to read it. They also do have a pocket guide, which is a shorter version of the full guidelines. And every year when they update it, which is updated annually, they do include a short PowerPoint or PDF that goes over what was updated in each section of the guidelines, as well as why it was updated. So based on new evidence or literature and things like that. So I find that super helpful and something to consider referencing as you enter into your clinical practice in the future, since things like this and guidelines can definitely change over time.
Hi everyone, my name is Rachel. I'm one of the PGY1 ambulatory care residents, and today I'm going to be talking to you guys about the management of chronic obstructive pulmonary disease, or better known as COPD. And these slides have been adapted from some of our previous residents, which include Shelby Cohen. Today we'll be going over some background knowledge on COPD. We'll look at the clinical manifestations and how we medically manage COPD, as well as looking at exacerbations. And then finally, we'll wrap it up with antibiotic do's and don'ts.
Hi everyone, my name is Jean Steenwijk, and today we'll talk about asthma management with a focus on the variety of medications we use in this disease state. Asthma is a chronic inflammatory condition characterized by airway inflammation, airway obstruction, and bronchial hyperresponsiveness. It is one of the most common chronic diseases in children. In this figure on the right, you can see a normal airway in contrast to an airway during an asthma symptoms. There is excess mucus production causing mucus plugging. There is thickening of the airway in both the basement membrane and the smooth muscle, and there is also airway constriction. The etiology of asthma is multifactorial. Genetics account for about 60 to 80% of a person's susceptibility to developing asthma. But there are also many environmental risk factors, and these are the most important precipitant for a severe asthma exacerbation. In children, the most significant precipitant of severe asthma is viral respiratory tract infections. These include RSV, rhinovirus or the common cold, and influenza. Another theory for the development of asthma is the hygiene hypothesis. This proposes that genetically susceptible individuals develop allergies and asthma by allowing the allergic immunologic system, which are the T helper cell type 2, to develop instead of the system to fight infections to develop, which is the T helper cell type 1, and may explain the increase of asthma incidence in developed countries. Other environmental risk factors include exposure to secondhand smoke, allergen exposures such as pollen, dust mites, and animal dander, and air pollution. This figure demonstrates the complexity of the various factors that can cause asthma. As you can see, our common triggers like tobacco smoke, infection, exercise, allergens are all listed here. But I want to draw your attention to the blue boxes because these are the key drug targets that our medications for asthma utilize to reduce the bronchoconstriction and relieve our patient's symptoms. In addition to the triggers shown in the previous slide, there is also another cause of asthma called type 2 inflammation. This is a systemic allergic response known to play a role in the atopic triad, which includes asthma, allergic rhinitis, and atopic dermatitis. As many as 50 to 70% of asthma patients have a form of asthma that's characterized by this type 2 inflammation. And so this is something that you should keep in mind if a patient presents to you with moderate to severe asthma symptoms, because these patients can benefit from biologics that target the cells and pathways that link inflammation to asthma. And we will talk briefly on these biologics toward the end of the presentation. To diagnose a patient with asthma, we need to first ask them about their history of symptoms. Their symptoms should occur variably over time and also vary in intensity. And these symptoms usually occur after triggers. So ask your patients, are their symptoms usually triggered by exercise or laughter, any allergens, or maybe even cold air? And also if the symptoms appear or worsen with viral infections. These all point you toward the path of diagnosing a patient with asthma. But in addition to the symptom history, they need to also have confirmed variable expiratory airflow limitation with spirometry. So this can be documented excessive variability in lung function or documented expiratory airflow limitation. And so the things that we look for with the spirometry include the peak expiratory flow, which will be measured as the highest of 3 readings, as well as the forced expiratory volume in 1 second. The common symptoms of asthma include coughing, wheezing, chest tightness, and shortness of breath. Now let's move into treatment. The next few slides will go over the main pharmacological classes used for the treatment of asthma. The actual algorithm for treating asthma is covered in a separate PowerPoint. The first class we'll talk about is the inhaled corticosteroid, or ICS. These agents target airway hyperresponsiveness, inhibit the inflammatory cell migration and activation, and block the late phase reaction to allergens. The inhaled corticosteroid class is the most effective long-term controller therapy for asthma patients. The onset of improvement is usually about a week. It is important for you to know that you should only use inhaled corticosteroids at the low or the medium dose, and really only reserve the high doses for severe asthma. And that is because corticosteroids are not without adverse effects. The most common adverse effect of inhaled corticosteroid is oral candidiasis, And this is why we tell patients that when they use inhalers with the inhaled corticosteroids, they should always rinse their mouth of water and spit it out afterward. Other adverse effects are hoarseness of voice, and it may slow bone growth in children. It's also important to recognize that there are some potential drug interactions with HIV medications containing ritonavir, which can lead to an increase in exposure to the corticosteroid in the body and leading to Cushing's syndrome. And so if your patient takes any HIV medication with ritonavir, you should prescribe them an ICS that has beclomethasone or fluocinolone. You should not use fluticasone, mometasone, or triamcinolone. Here is a table showing the various inhaled corticosteroid products and their dosing, separated in terms of low dose, medium dose, and high dose. It's important to note that this is not a dose equivalency table. In order to determine which inhaled corticosteroid you should select for your patient, it will really be largely dictated by your insurance plan as well as the affordability. Next, we'll talk about short-acting beta agonists, or SABAs. These are also another workhorse for the treatment of asthma. SABAs are bronchodilators, selectively working on beta-2 receptors in the airway smooth muscles. It's important to note that these are only used as needed as the reliever inhaler, and regular use of these inhalers can indicate poor asthma control for the patient. The effect of these inhalers will last about 3 to 4 hours, and the adverse effects are typically mild, but if used very often, it could lead to tremor or tachycardia, or even in severe cases, electrolyte imbalances. The two main products are albuterol and levalbuterol. Levalbuterol is the R enantiomer of albuterol. It is twice as potent, so the dose is half of that of albuterol, but it is also more expensive. Most commonly, you'll see albuterol being dispensed as Ventolin or ProAir. The next class has a very similar name to the last class, and these are the long-acting beta agonists, or LABAs. So they also selectively agonize the beta-2 receptors, but they last longer, typically about 8 to 12 hours. The most important thing to know about LABAs in the treatment of asthma is that they should never be used as monotherapy for long-term treatment. And that is because LABAs can desensitize the beta-2 receptors, so that the emergency bronchodilation would not be effective. There is even a boxed warning for increased risk of asthma-related deaths with salmeterol and an increased risk of severe exacerbation with formoterol. So you will see LABAs being used in combination with the inhaled corticosteroid class for long-term control in step 3 therapy or higher in patients over 5 years old, or in step 4 therapy or higher in children aged 0 to 4 years old. In the new GINA 2019 and 2020 guidelines, they recommend using a low-dose inhaled corticosteroid formoterol combination as needed as the reliever inhaler in mild asthma, which is in step 1 and step 2 therapy. Again, LABAs are the preferred adjunct to inhaled corticosteroid to improve lung function, decrease symptoms, and reduce exacerbations. Possible adverse effects include nasopharyngitis, upper respiratory tract infection, and headache. Here is a list of all of the inhaled corticosteroid and long-acting beta agonist products. You may be familiar with these brand names such as Symbicort, Advair, Briolipta, and Dulera. For the new guideline recommendation, Symbicort was what was studied in the trials, but the Dulera is another option if patients were to use this as needed in mild asthma. Next, let's talk about the leukotriene receptor antagonists. So what is leukotriene? Leukotrienes can cause airway edema and smooth muscle contraction after allergen exposure. So when we block these receptors, it can counter the respiratory inflammation. These are alternative therapies at step 2, but are not preferred over the long-acting beta agonists. The most common one is Singulair or Montelukast. This is given as a one-time oral tablet or even as chewable or oral granule packets. Once a day, usually given at night. It's important to note that earlier in 2020, the FDA added a box warning for the risk of serious neuropsychiatric events, including suicidality in adults and adolescents and nightmares and behavioral problems in children. The other two agents in this class, Accolade and Zyflo, are less commonly used, and that is because they both have risk of hepatotoxicity. And if a patient was started on Zyflo, they must monitor liver function tests at baseline and very frequently afterward. Another class of agent that you may see in the treatment of asthma exacerbation is systemic corticosteroids. So these are used during acute exacerbation to speed the resolution and to prevent relapse. These can also be considered as an add-on in step 5. The oral route is preferred, but it takes at least 4 hours to see a clinical improvement. You could use IV steroids if the patient is too dyspneic to swallow, if the patient is vomiting, or if the patient requires intubation. The IM route may be appropriate at discharge if there's concern about your patient's adherence, but there's really no benefit of giving an IM steroid over PO. The typical dose for an exacerbation will be about 50 milligrams per day for 5 to 7 days in an adult, and about 40 milligrams per day or 1 to 2 milligrams per kilogram per day for 3 to 5 days in children. And there has been no benefit shown in tapering dose. Now let's talk about some less commonly used agents in the treatment of asthma. The short-acting muscarinic antagonist, or SAMA, works by inhibiting the muscarinic acetylcholine receptor and reduces the intrinsic vagal tone in the airways. The only agent in this class is ipratropium. You've probably seen it in the nebulizer Deoneb, which is a combination of ipratropium and albuterol. And that is because ipratropium should never be used alone for asthma, and it is only used in addition to albuterol in moderate to severe exacerbations in the ER setting only. Some possible adverse effects of this drug is headache, flushed skin, blurred vision, tachycardia, and palpitations. The counterpart to the short-acting muscarinic antagonists are the long-acting muscarinic antagonists. These are typically only used for COPD, except recently Spiriva Respimat or tiotropium became indicated for long-term maintenance treatment of asthma for those over the age of 12, and they have similar adverse effects compared to the short-acting muscarinic antagonists. The methylxanthines work by producing mild to moderate bronchodilation by blocking phosphodiesterase and increasing cyclic AMP. The two drugs in this class are theophylline, which is PO, and aminophylline, which is IV. This class is different because you have to monitor serum peak concentrations to maintain it between 5 to 15 micrograms per ml. And they also have a lot of side effects, including nausea, vomiting, headache, and tremor. So it's not very tolerable for the patients. Therefore, we rarely use this class of medication anymore for the treatment of asthma. And finally, let's talk about these new biologics, or immunomodulators. These are all monoclonal antibodies designed to target specific targets in the immune system. So first, we have an IgE binding inhibitor, or Xolair. The generic name is omalizumab. These are for allergy-related asthma and is given as a sub-Q injection. Next, we have IL-5 antagonists, and these are for patients with an eosinophil phenotype. And the agents include two sub-Q injection products, Nucala and Fasenra, as well as an IV infusion product named Syncare. Next, we have the IL-4 antagonist. This is also indicated for patients with the eosinophil phenotype. And the only drug in this class is Dupixent. This is given as a sub-Q injection. As you can imagine, these new biologic agents are very expensive, and the patients also need to trial these products for at least 4 months. But these products are great options for our patients who have the type 2 inflammation-related asthma. Retrospective studies have shown increased risk of asthma exacerbations and asthma-related death with more canisters of short-acting beta agonists like albuterol that a patient fills. Use of 3 or more SAVA canisters per year was associated with increased risk of asthma exacerbations, and use of 12 or more SAVA canisters per year was associated with increased risk of asthma-related death. Now, it may not mean that this particular medication is dangerous for the patients. The problem is that patients who use their albuterol inhalers so frequently may not seek care from their healthcare provider to get on a controller inhaler. While the albuterol inhalers can provide some immediate relief, it is not the safest option in the long term. The aim of this change in recommendation is to reduce the probability of serious adverse outcomes at a population level. Once initial treatment is started, it is important to revert back to the arrow circle of assess, adjust, and review response. If your patient does not have symptom control, remember to check factors beyond pharmacotherapy, such as comorbidities, inhaler technique, and etc. If your patient has maintained good control for at least 3 months, you can consider stepping down therapy. You want to make sure the patient is on board and that there are no travel plans or any respiratory infections during the step-down time. Your patient should always have a written asthma action plan, but it's even more important to provide clear instructions on the plan when stepping down therapy. We have discussed a lot of different medication classes as well as products, so let's wrap up with some take-home points. Inhaled corticosteroids, or ICS, is first-line controller inhaler for maintenance therapy. As neither a short-acting beta agonist or low-dose inhaled corticosteroid formoterol can be used as a reliever inhaler. Leukotriene receptor antagonists are good for patients with allergies, but beware of side effects. Short course of oral steroids can be used for acute exacerbation. And new immunomodulators are options for difficult to treat asthma.
Hey everyone, my name is Rachel. I'm one of the PGY1 Ambulatory Care Pharmacy residents, and I'm really looking forward to seeing you all in class soon. Today we will be going over allergic rhinitis and cold and cough, and these slides have been adapted by some of the previous residents, including Chris Walston and April Anderson. And here's a quick overview on what topics we're going to be talking about today.
We're going to start off by discussing allergic rhinitis, and as you can tell from this picture here, most of the symptoms are related to runny nose or postnasal drip, itchy nose, throat and eyes, that's why they're red and swollen, and can also experience some sneezing as well. Allergic rhinitis affects roughly 15 to 20% of the U.S. population, and it's the fifth leading chronic disease in the U.S. and the third leading chronic disease in pediatrics. And in a lifetime, it will affect up to 30% of adults and 40% of children. It gradually declines in later years of life, so you won't see as many geriatric patients with allergic rhinitis as you will younger patients. And in our younger patients, it seems to be more common in boys than girls. But then after that adolescent stage and into adulthood, there becomes a smaller difference in sex between the difference of presence of allergic rhinitis. Also, another risk factor for increased likelihood of allergic rhinitis is higher socioeconomic status. Typical symptoms of allergic rhinitis include things like sneezing, itchy nose, itchy eyes, throat or ears, clear rhinorrhea, so like clear fluid draining from the nose. That could be out the nose or postnasal drip, watery eyes, nasal congestion, cough, conjunctival edema, itching, tearing, or subocular edema or darkening. That's called shiners, or mouth breathing and or sleep disturbances. So we're going to start off by talking about some non-pharmacological strategies to mitigate allergic rhinitis. So some of the things that you may want to consider are when we start talking about medications, using those prior to a known allergen exposure. Like, for example, if someone knows that they're allergic to cats and they know they're going to go over to someone's house that has a cat, trying to medicate prior to that exposure is more beneficial than waiting until later after the exposure. Another thing non-medication related you can do is in your home try to set up HEPA filters. That cleans and purifies the air a little bit better. In general, obviously it's easier said than done, but avoiding allergen exposure such as smoke or animals, whatever triggers the allergic rhinitis, trying to avoid that if at all possible. Can also wear a mask or goggles or other protective equipment. This is especially beneficial if patients are allergic to grass, or if they have to mow the lawn, things like that, or if their occupation exposes them to something that causes or triggers their allergic rhinitis. Obviously, keeping the windows closed in the home instead of letting the outside allergens in that may trigger their allergic rhinitis. Minimizing carpet in the house is an easier way to also mitigate this. Carpets tend to trap and keep dust and other things inside them more so than laminate or hardwood, things like that. And obviously keeping your home clean and tidy and trying to keep the humidity low is also best. And then trying to control pests, and then watch pollen counts as well as we go into the spring. I'm going to go into the drug class more specifically on the subsequent slides, but on this slide I just want to bring up the comparative efficacy for each of the agents we're going to discuss for allergic rhinitis, and then their efficacy for each of the symptoms that may be more predominant in one of your patients. So this can kind of help you drive your selection choice of what agent you may use, depending on what symptoms are most bothersome to your patient. So antihistamines are pretty good across the board, but especially if your patient is having sneezing or rhinorrhea, that clear nose drip or postnasal drip, antihistamine seems to be really effective in this area. Likewise, intranasal steroids across the board seem to be really effective and have better efficacy than antihistamines in the congestion area and equal efficacy in eye symptoms. And decongestants, they don't really help with anything other than congestion. So that's easy to remember. The name decongestant only works for congestion for the most part. Has a little bit of symptomatic relief for like eyes, but otherwise just think of it as only using that for congestion relief. And the leukotriene receptor antagonist, montelukast, is minimally effective at reducing symptoms from each of these things, but not as great compared to antihistamines or intranasal steroids. Continuing into some clinical scenarios you may encounter, this slide gives you an idea of what recommendation you should be making based on the given scenario. So let's say your patient comes in with intermittent sneezing, itching, and rhinorrhea. Your recommendation could be one of two things. It could be an oral antihistamine or an intranasal antihistamine. Again, right now we're just going to kind of review the class, and I'll give you some specific examples of medications in each of those classes in the coming slides. Next scenario you may encounter is just nasal congestion or persistent symptoms after treating with other things. You may want to consider, in this case, an intranasal steroid or an oral decongestant. If someone in general just has mild symptoms, they're experiencing a little bit of everything, the sneezing, coughing, eye symptoms, everything, you may want to consider one of the more versatile agents such as an oral or intranasal antihistamine. And then if they're more moderate to severe symptoms, you may want to do an intranasal steroid alone, or you can combine that with an intranasal antihistamine. Now we're going to begin to review each of the medication classes more specifically. So we're going to start out with H1 antagonists, or our antihistamines. These medications exert their physiological effects by stabilizing the inactive form of H1 histamine receptors, therefore preventing histamine from stabilizing the active form of H1 receptors. Inhibition of this activation results in decreased capillary permeability, reduced mucus production, relaxation of smooth muscle, and reduced vasodilation. The clinical manifestations of these effects reduce sneezing, reduce nasal pruritus, reduce itchy watery eyes, and reduce rhinorrhea. Now that we know how the H1 antagonists or antihistamines work, we have to look at the classes even a little bit further. They come in 3 different generations, and some are over the counter and some are prescription only. But we're going to look at on the next slide a couple of the differences between the first and second generations. The only third generation available is Allegra, but for the most part, the things I want to point out are similar to the second generations. So there's not really anything you need to memorize specifically from that standpoint. Mostly we're just going to differentiate what's different between the first and second generations. So the main differences between the first and second generations are listed here for you. The first generations are cheaper. They're all available over the counter. One of the downsides, though, is that you have to use them every 4 to 6 hours. However, they are highly effective, which is why they're given if someone is having an allergic reaction. A lot of times you'll recommend giving Benadryl or something like that if patient is able to take that, because it is highly effective. However, it does cause drowsiness in a lot of cases, and it does exhibit a lot of anticholinergic effects because there is a higher CNS penetration, and a lot of these effects may be like sedation, dry mouth, urinary retention, constipation, and or blurred vision. And so because of that, we have to use caution using first generation agents in patients who have glaucoma, or if they have trouble urinating, or if they have respiratory disorders, thyroid disease, or heart disease. Second generations are a little more costly. They're still very, very affordable in most cases. Some of the over-the-counter ones that are brand name only are still kind of expensive compared to the first generation ones, but there's still a lot of generic Claritin or Zyrtec available options that are very cheap. They have lots of OTC options and some prescription-only options. For the most part, most of these agents are only used once a day, so that's very convenient for patients. They are pretty effective in most cases, but slightly less effective than the first generation. However, since they are second generation and are a little bit less effective, they do have some benefits such as less or no drowsiness and less anticholinergic effects, which can be beneficial for lots of our patients, especially the ones I mentioned you have to use caution in first generation agents. They could definitely more than likely use a second generation agent. This slide is just pointing out a unique factor within the second generation antihistamine class, comparing adverse effects with cetirizine, desloratadine, fexofenadine, and loratadine. Basically pointing out here on the slide, I just want to show you that Zyrtec or cetirizine out of the second generation class has been shown to have more drowsiness or somnolence, more fatigue, and dry mouth when compared to all the other ones. So although it is a second generation, you can almost consider it like a generation 1.5, or think of it that way, because it's not quite generation 1 where it's got a lot of drowsiness and sedation or anticholinergic effects, but it does have more than the other second generation antihistamines. So keep that in mind. And generally, if I recommend cetirizine or Zyrtec for someone, I recommend that they take it at bedtime in the event that they do get sedated or that fatigue, dry mouth, that all at night, that's more appropriate, I guess. So typically all the other ones can be taken any time of day, morning or night, but usually cetirizine I recommend be taken at bedtime. So we just discussed our oral antihistamines. So these have very similar mechanism of action. They're just intranasal instead of oral. So the two that I'm going to talk about here are azelastine. These come as prescription only as Astelin or Astapro, and olopatadine or Patinase is available prescription and OTC. The advantages of these are that it's really useful for episodic symptoms, targeted treatment in the nose where a lot of the symptoms are kind of going on. You can pre-treat with these, and very beneficial in patients who are refractory to or not able to tolerate oral meds as well. There's less systemic effects and drug interactions when you use the intranasal route, and the onset is typically a lot quicker. It's 15 minutes usually, and they usually last for about 4 hours, so sometimes these will have to be given multiple times a day. Some of the disadvantages, though, are that they don't really help much with congestion. Since they are antihistamines, they're not going to benefit you as much with the congestion, if you'll remember from the slide above with the pluses. Other things as far as side effects could cause headache, drowsiness, nasal irritation, a bitter taste if it drips down the throat or back of the nasal cavity, and they may have less efficacy over time of use. And then many times these have to be given twice daily. So just to compare the oral versus intranasal, oral onset averages about 150 minutes or just over 2 hours, whereas intranasal is very rapid, 15 to 30 minutes, you'll see the effect. Oral has more systemic adverse effects than the intranasal route. And then also both of these have limited efficacy for congestion, but the intranasal does have a little bit more efficacy compared to the oral. And then the oral is nicer. Usually it's only once a day. Some are twice a day, but majority of the time the oral antihistamines will be once a day dosing, whereas the intranasal are usually twice a day. Next, we're going to talk about our intranasal steroids. Overall, these have really great efficacy for everything that you may experience during allergic rhinitis, minus the eye symptoms. So anything from sneezing, itching, rhinorrhea, congestion, this would be a great choice of agent to use. Typically, they're most effective if you can initiate therapy before the allergen exposure. And the downside with these agents, a lot of times the onset is pretty slow, and maximum benefit is not seen until after about 2 to 3 weeks of use. And a lot of times patients will use these for a few days and then not see any benefit and give up before they reach that maximum efficacy after about 2 to 3 weeks. And they do have a really slow onset time as well. So that's important to let your patients know that it's very different from the intranasal antihistamines, which you'll notice a very rapid benefit in about 15 to 30 minutes. These is very slow, could be between 3 to 36 hours depending on the agent. And ultimately, you're not going to get the maximum benefit from these until about 2 or 3 weeks. And there's several different agents we're going to go over within the class, but they all have very similar efficacy. Just pretty much is going to be down to price or patient preference. There's, like I mentioned, not as beneficial for eye symptoms, but can be a little bit of benefit, especially from the anti-inflammatory standpoint. So it may help from like the redness or puffiness, but not as much as with the itchiness. As far as side effects, they may cause some stinging or headache or epistaxis is possible. But ultimately these are very beneficial agents, and you may need down the road to reduce the dose once the response is achieved. But generally speaking, these are very good choices for a majority of our patients. However, it is important to mention that you may want to avoid use of these agents in patients with nasal septum ulcers or recent surgery or trauma in their intranasal cavity. So here's a list of the intranasal steroid options that are available. As you'll see, many of them are available over the counter, and some of them are prescription only. So you can recommend either one based on whatever the patient wants. Many of these are able to be used 1 to 2 sprays once or twice a day, depending on the agent. And then another thing I've wanted to point out on this slide too is that some of these agents have a drug interaction with some of our HIV treatments, and which could lead to Cushing syndrome. So if a patient is on HIV treatment, beclomethasone and flunisolide are the preferred agents, and it is contraindicated to use fluticasone, mometasone, and triamcinolone. Like most things, we have to make sure our patients are able to use the product appropriately so that we can assess, make sure it's actually working for them and helping them out with their symptomatic relief. So I included this slide to kind of show the best way to counsel your patient on how they should be using their intranasal medications. This applies to intranasal steroids or intranasal antihistamines, but you're going to tell your patient to start out by clearing their nostrils by blowing their nose. And then no matter what product it is, you'll have to shake the bottle gently. And then instead, a lot of times patients, what you'll see is they'll tilt their head backwards. But what you want to actually tell them to do is tilt their heads forward slightly, as you see in the picture here, number 3. And then what you'll do is put one finger over one nostril and then place the spray pump tip slightly into the nose. You don't have to push it way up in there. And then when you do spray, don't spray it directly towards or onto the nasal septum. You want to kind of just spray it directly straight up or out away from the septum. Because some of these agents, especially the intranasal steroids, if you repeatedly administer the medication right on the septum, you could create a deviation or a cavity between the septum, which you don't want. You want to keep that septum intact. And then ultimately, throughout the process, make sure you keep the bottle upright and pump once firmly whenever you're ready and you've got everything kind of set up, steps 1 through 5. And then as you spray, breathe in through your nose gently, not forcefully. And then you'll repeat these steps with the other nostril. And then also caring for your product is essential as well. You want to wipe off the tip with a clean tissue at the end, and then replace the dust cap to keep it clean and sanitary. And then if you don't use your spray for 14 or more days, you'll need to prime the pump again. So initially when you first get a intranasal product, you'll have to prime it with about 2 sprays before, like I just do it in the sink typically, and then your product will be ready for use. So now we're going to move into talking about our oral decongestants. As we talked about earlier, these are pretty much only effective for the congestion symptoms of allergic rhinitis. The 2 available products we have in this category are pseudoephedrine, Sudafed, or phenylephrine, which is confusingly called Sudafed PE. Both are available over the counter, but pseudoephedrine you have to show proof of your driver's license, and there has to be documentation of purchase of the product, whereas phenylephrine or Sudafed PE, you do not. Side effects of these medications could be increased blood pressure and heart rate, CNS stimulation, or urinary retention. So you just have to be careful with these agents in patients who have uncontrolled blood pressure or things like that, or seizures, things like that. You want to avoid use, again, these patients who have BPH or glaucoma, maybe not the best ideal agent in the elderly or cardiovascular disease, hyperthyroidism, not great in children or pregnancy either. Also another consideration, mothers who are like breastfeeding, it can dry up their milk, so not an ideal candidate to receive an oral decongestant in that case either. And then you'll want to counsel your patients to use them pretty much only when they need them. You don't want to take these around the clock. And because they cause stimulation of the CNS, typically it's better to take these in the morning if possible, because if you take it close to bedtime, it may be difficult to go to sleep. As far as Sudafed, it's available, the pseudoephedrine, it's available in a lot of different immediate release or extended release products, and it could be combined with an oral antihistamine as well, as you'll see that you can purchase behind the counter as well. So comparing these two agents, I think the key takeaway here is that ultimately, since the studies have been done on these agents, phenylephrine has been shown in two different studies to not be more effective than placebo. So I typically never recommend this product. If someone is having congestion, I usually recommend, and if they're not contraindicated to any treatment, I usually recommend pseudoephedrine or Sudafed, which they'll have to purchase from behind the counter, because that seems to be the more effective agent in relieving their symptoms. So you may see this as well, a product called Coricidin HBP. It's marketed as a decongestant alternative for patients who are not able to take pseudoephedrine. It's supposed to help with cough, runny nose, and sneezing. But let's look at what's really in it and whether it's worth it or not. So it's kind of an expensive product, and basically it has a cough suppressant in there plus diphenhydramine in most cases. So honestly, it's probably, if your patient doesn't mind taking 2 tablets, it's cheaper to buy the generics of the active ingredients instead of buying this product itself. For 16 tablets, I think it usually runs about $20, but you could buy each of the individual products for probably less than $5 in most cases. So it's just kind of a marketing thing, and it's not harmful in any way. According to the box, the AHA recommends this product, and it's definitely safer than taking pseudoephedrine for patients who have high blood pressure. So if you're worried that they won't buy the right products over the counter, then you could recommend this product. But otherwise, I think it's probably cheaper to just buy the generic medications that are in this product. So now that we've talked about oral decongestants, we can move on to nasal decongestants. So some of these listed on the screen here for you are phenylephrine, oxymetazoline, and tetrahydralazine. Some of these are OTC and some are prescription only. The most common one I think you'll probably see is Afrin. The key takeaway on this slide here, I think, is the starred information down at the bottom, is make sure your patients know to limit therapy to 3 to 5 days for these. So the reason for this is that if you use it longer than 3 to 5 days, you'll experience rebound congestion. So honestly, the patient should be using the smallest dose as infrequently as possible. And try to wean, if patients have been on this for a really long time, they'll have to wean themselves off. They won't be able to really quit abruptly because of the rebound congestion that they will experience from this. So you may experience this at some point in your career, that someone may be, they may think or say the word addicted to this, but more so they're kind of dependent on this, as they are going to experience rebound congestion if they ever stop taking it. So that's something you may have to work through and help your patients wean off of. But ultimately, these products are more effective than the oral agents, And since they have less systemic absorption, they're going to experience less side effects in general that we discussed, less blood pressure increase, things like that. But they may experience some burning or stinging on administration in their nose, things like that. And these also have really fast onset of action. I don't know if you've ever tried these or not, but they work very rapidly if you have congestion. Usually in about 2 minutes or so, you'll notice some relief of congestion. So they're very reliable agents, but the thing is you want to make sure your patients are aware that they should not use these more than they actually need them. I touched on these a little bit before, but now that I've covered all of the antihistamines and decongestants, I wanted to just list a slide of the combination therapies you may see. A lot of these products are behind the counter. On the top section here, the Claritin D, Zyrtec D, Allegra D, and Clarinex D. These are all combined with Sudafed, so they have to be purchased behind the counter with a driver's license. But these are also very effective one-tablet regimens. Some come in 12-hour formulations and some in 24-hour regimens. That is very nice to have it combined into one pill for patients that don't want to take a lot of different pills. And then also I wanted to mention the intranasal antihistamine plus nasal steroid. It's prescription called Dymista. I think this is pretty expensive still, brand name only, so you may need to look for coupons or things like that so that your patient can afford it. It's a great medication, but a lot of times insurances may not cover it or maybe a high copay, so that's just a consideration. And this slide here gives you an idea of some considerations you may want to make as you're considering therapy escalation. So if your initial therapy is not enough and you need to add something else onto it or make a switch, this would be a good reference for you to use. So if you're starting with an intranasal steroid and they're still having symptoms and are requesting something else, you may want to recommend adding an intranasal antihistamine or a nasal decongestant depending on what their symptoms are. Likewise, if you start them out on an oral antihistamine, you may want to switch them to a intranasal steroid or an intranasal antihistamine, or you could consider adding a oral decongestant or a leukotriene receptor antagonist. Then lastly, if you start them out on an intranasal antihistamine, then you could consider adding an intranasal steroid on top of their therapy. In this slide, I've listed a lot of the ophthalmic agents that you may see used for itchy or watery eyes or eye redness and congestion. I'm not going to read them all to you, but I have bolded the most common ones that you'll see, and several of these are available over the counter and some are by prescription only. But just keep in mind to use the appropriate one because some of them are more antihistaminergic, which would help more with the itchy watery eyes, and some are more for the congestion and redness. So just pay attention to the correct agent for which you're trying to get the desired effect. And my understanding is that you have a separate presentation going more in depth into ophthalmic agents, so I'm not going to spend extensive time going on to that here. Lastly, I wanted to list a couple other considerations of things that you may use in your career. So we have talked a little bit about nasal saline and its use, and it can be used pretty much in anyone, but it's definitely one of the preferred agents for pediatrics at any age and pregnancy and lactation. So one of the main products I like for this is called NeilMed Sinus Rinse. Basically comes in like a squirt bottle, and it helps decrease nasal congestion through kind of like force. In a way, you kind of like squirt the saline rinse up into your nose, and it kind of helps break up some of that congestion in there. And then you will sometimes see the neti pot being used for a similar thing like that as well. You just have to make sure that you use sterile water. They may need to boil it and make sure they're not putting contaminated or bacteria water in rinsing it through their nasal passages. That would not be ideal. So you just have to make sure they're using that appropriately. Additionally, Cromolyn or nasal crom is available over the counter as well, and as well as leukotriene modifiers may be available as RX. These two agents are beneficial for sneezing, itching, and rhinorrhea. And nasal crom, I think its place in therapy is more so as prevention. So if it doesn't work immediately per se. It's best if you can use it in anticipation of an event, such as if you know you get seasonal allergies every March when the pollen counts start to rise, you may want to start using this several weeks prior so that it's working when the time comes that you need it to be effective. I have heard some success with people using it prior to going to somewhere where they know that they're going to be stimulated or have allergic rhinitis symptoms, such as if someone is going to go over to someone's house and they're allergic to cats, this person has a cat, if they use this before they go over there, it may decrease some of the sneezing, itching, and rhinorrhea that they may experience during and after that exposure to the allergen. And for the leukotriene modifiers, also wanted to mention that has similar efficacy to loratadine and additive efficacy if it's added on to loratadine, and it generally seems to be pretty well tolerated. Then as far as immunotherapy and IgE therapies, these you may see in more severe allergic rhinitis cases, but you want to avoid these in immunotherapies in uncontrolled asthma or cardiovascular disease. And anti-IgE may be more suitable if they have the allergic rhinitis with asthma. For the nasal ipratropium, that is available as a prescription as well. That may be something useful to you. So I already talked about this a little bit on the previous slide as the leukotriene modifier, but montelukast, like I mentioned, has similar efficacy to our second generation antihistamines and has an added benefit if you combine the two. Also has an additional role in helping patients with coexisting asthma, but I did want to mention on this slide too the adverse effects that may be associated with its use. So it may cause upper respiratory tract infections, headaches, or abnormal dreams. And another notable side effect or warning that has been presented by the FDA is neuropsychiatric disorders. So if your patient is mentioning that they've suddenly become more aggressive or more depressed or having suicidal ideation after you put them on this medication, you may want to consider getting them off that therapy or not consider starting therapy on patients who are already experiencing these disease states listed here. So in summary, your treatment should mostly be symptom guided and patient centered based on their age, other health conditions, cost, all that kind of plays a factor into your choice of agent. And then additionally, I just wanted to kind of touch on some targeted approach examples again. So if patients, most of their symptoms are related to itchy, runny nose, then your agent of choice would be an antihistamine here. If most of their symptoms are related to congestion, then your most effective agents would be using a nasal steroid or decongestants, sparingly, remembering the intranasal ones only using for 3 to 5 days. And you could also use nasal saline. It's the safest option in this category. For itchy eyes, ketotifen or olopatadine eye drops would be your preferred agents here in this category. And if they're just having a runny nose only, nasal ipratropium or cromolyn may be your best bet here. So now that we wrapped up allergic rhinitis, we're going to transition into talking about the common cold. The common cold can be confused with allergic rhinitis easily, so I wanted to point out some key differences between a common cold and allergic rhinitis. There is a lot of overlap, but some of the key differences would be things like sore throat. The things that do overlap would be the congestion, the runny nose, but typically the things that differentiate it would be, maybe plus or minus fever, body aches, fatigue, and that sore throat. And typically with colds, that sore throat usually appears first before any other symptoms. And the duration is usually limited, whereas with allergic rhinitis, the duration is intermittent or seasonal, or it can tend to be persistent throughout the year in some people. And onset usually happens around the time of high pollen counts or around the time of certain allergen exposures for allergic rhinitis. So some of the common cold treatment options you have here are zinc or vitamin C that you can recommend. So we'll talk about zinc first. Zinc can shorten the duration of colds, usually by about 1 day if you begin treatment within 24 hours of symptom onset And the key thing here is that it has to be administered every 2 hours, which can be a nuisance in some cases. Some of the products that you'll see are the Zicam tablets that contain zinc, or the Zicam nasal formulations. Some of the things to know, though, especially with the nasal one, that it can cause some anosmia. And then additionally, zinc in general, side effects could include nausea, vomiting, or metallic taste. It is a metal, so that does make sense that it would cause that. In general, it can be helpful, but generally only shortens the cold by about 1 day, though. Then moving on to vitamin C, also can reduce the duration of colds in general population, and generally contributes to a healthy immune system. And the dose is typically around 2 grams per day. And it also has shown to prevent cold symptoms in a population under high stress as well. So you can use it as treatment and prophylaxis in a way. So here are a couple options for sore throat. You can recommend Cepacol or other sore throat lozenges, or Chloraseptic, which is a sore throat mouth spray. And additionally, you can recommend oral NSAIDs such as Aleve or Advil, ibuprofen, or Tylenol as well. Lastly, we're going to discuss cough. Your cough treatment will depend on whether the patient is experiencing non-productive or productive cough. The difference between the two is if it's more of a dry, hacking cough versus a cough that someone feels they have chest congestion or need to cough up some phlegm. And if it's the non-productive type, then you would recommend more treatment with dextromethorphan or with codeine products. Whereas if it's a productive cough, then you could recommend guaifenesin. So guaifenesin is what I mentioned on the previous slide as an option if a patient is experiencing productive cough, meaning that they have to cough up some mucus or phlegm. And so it's an expectorant, and so how it works is it tries to thin and loosen the mucus to make it easier to cough up. However, there have been some studies done on it to show that it is essentially no more effective than placebo, and it's actually just as good as drinking a large amount of water. And in order to accomplish this, it's not just going to be a little bit of water. Your patient is really going to have to drink a lot of water for it to work. So if your patient is willing to drink a lot of water instead of taking this medication, it should be equally as effective. But if you don't feel that your patient is going to be able to drink an adequate amount of water, then you may want to recommend the guaifenesin in addition to a good amount of water in order for it to best work. And also with this, you're going to want to encourage your patient to try to cough it up as much as possible, because the medication is going to help loosen it up and thin it out. But ultimately, in order for them to get better, they're going to need to cough it up and spit it out. So moving on to some of our non-productive cough agents, I think the most popular one here will be Delsym. It works for 12 hours, which makes it the ideal agent to use right before bed, especially for patients who are coughing at bedtime or don't want to have to wake up in the middle of the night to take another dose. There is another dextromethorphan product called Robitussin, but it only works for about 4 to 6 hours. So that one would not be ideal for bedtime, but could be used throughout the day if patients prefer a shorter duration of action. Additionally, you could prescribe codeine, but just remember that's a controlled substance. It is really effective for controlling cough, though, so you could consider that. Initially, you could consider using Benadryl or first-generation antihistamine before bed. It can also help with a non-productive cough. Just be aware that the package says it's only for age 6 and up, because not that it's not safe in patients that are younger, but because I think there were some issues with parents using it, giving it to their children to help them go to sleep. But paradoxically, it could actually cause hyperactivity in some children, so you just have to kind of watch out for that and be careful with your recommendation of that. Additionally, you could use menthol cough drops or menthol plus camphor Vapo Rub. Both of these could also be helpful in controlling non-productive cough. And also I wanted to mention, similar to the guaifenesin, comparing that to water, wanted to compare dextromethorphan to honey here and just reveal that in conclusion, honey seems to work probably a little bit better than dextromethorphan in controlling non-productive cough. So some patients may want to try that, and that's totally fine if they prefer that. So that could be a route you could encourage as well. And you'll see this product too. It's called Mucinex DM. It is a combination of dextromethorphan and guaifenesin. And, I see this product a lot, but I don't know that I recommend it all that often. The product, to me at least, seems a little counterintuitive because the guaifenesin is supposed to help thin and loosen the mucus to help you cough it up. But then the dextromethorphan is suppressing your cough, so it kind of seems counterintuitive. And the best way, I think, to use these products together would be to use a decongestant in the morning, and then the antitussive at bedtime to help with sleep. I think it could be problematic to cough throughout the day, but definitely at night, I think dextromethorphan makes more sense to be used alone. And then you could use a decongestant or guaifenesin alone during the day, but I don't usually recommend this product, Mucinex DM, when combining these two because the mechanism of action just doesn't make sense when used together.
Rhinosinusitis can be divided into viral versus bacterial and acute versus chronic. Viral rhinosinusitis is self-limiting and usually resolves without treatment in 7 to 10 days. Bacterial rhinosinusitis is defined by 3 different clinical presentations, which we'll discuss in the next few slides. For acute versus chronic, acute rhinosinusitis is typically lasting less than 4 weeks, whereas subacute is the period between acute and chronic rhinosinusitis. And then chronic is for patients that have greater than 12 weeks of sinus inflammation. There are 4 cardinal signs of chronic rhinosinusitis, including anterior-posterior purulent drainage, nasal obstruction, facial pain, and decreased sense of smell. Patients would often need to be referred to a specialist if they have symptoms lasting for more than 12 weeks. It's important to differentiate between bacterial and viral clinical presentations of rhinosinusitis since this directs our therapy. As you can see in the graph, viral rhinosinusitis is high in severity in the beginning with a fever, and then decreases quickly over time, whereas the respiratory symptoms increase to a peak within 3 to 4 days and then decrease and resolve within 10 to 12 days. There are 3 clinical presentations of bacterial rhinosinusitis that help us direct our therapy more towards a bacterial cause versus a viral cause. Those 3 clinical presentations include persistent symptoms of 10 or more days without evidence of clinical improvement, onset of severe symptoms or high fever at the beginning greater than 102, and purulent nasal discharge or facial pain for 3 to 4 days. And lastly, onset with worsening symptoms after an initial improvement period, with new onset fever, headache, or increase in nasal discharge. After we've used the 3 clinical presentations to determine that a patient has bacterial rhinosinusitis, we then need to assess their risk for antibiotic resistance. Those risk factors are listed there on the right of this chart. After assessing for risk, we then initiate therapy. If the patient has no risk factors, they can be started on first-line antimicrobial therapy, which we'll discuss in a minute. But if they do have risk factors, then they need to be initiated on second-line antimicrobial therapy in order to overcome some resistance. If the patient has improved on antibiotics in 3 to 5 days, they need to then complete the total course of 5 to 7 days of therapy for adults or 10 to 14 days for children. If they have worsening symptoms or no improvement in 3 to 5 days, it is recommended to broaden antibiotic coverage and then treat for 5 to 10 days total. If the patient is started on second-line therapy, they've improved for 3 to 5 days, you do a total of 7 to 10 days. For empiric antibiotic coverage, it is recommended to use Augmentin as a first-line agent in children and in adults. In those patients that have a penicillin allergy, doxycycline, or a fluoroquinolone that has respiratory coverage may be considered. Second-line options include fluoroquinolones, clindamycin, macrolides, Bactrim, doxycycline, or a second or third generation cephalosporin. Adjunctive therapies for bacterial rhinosinusitis include saline irrigation, as well as intranasal steroids in patients that have a history of allergic rhinitis. As far as symptomatic treatment, for pain and fever, we can use NSAIDs such as ibuprofen or acetaminophen. Decongestants are not recommended in bacterial rhinosinusitis. However, if a patient has viral rhinosinusitis, these agents may be used. The antibiotic of choice in bacterial rhinosinusitis is Augmentin, which is composed of amoxicillin and clavulanic acid. Amoxicillin is a bacterial cell wall synthesis inhibitor and binds to penicillin-binding proteins, or PBPs, to inhibit cross-linking of the cell wall. This leads to bacterial cell lysis. Clavulanic acid binds to and inhibits beta-lactamases that are produced by the bacteria in order to inactivate amoxicillin, and therefore results in amoxicillin having an expanded spectrum of activity. The main side effects of Augmentin include diarrhea, GI upset, and rash. It's contraindicated in patients that have penicillin allergies due to the fact that amoxicillin is within the same class of penicillin. For patients, it is important that they take the medication with food in order to reduce upset stomach, and there's also a suspension available for children. The next class of antibiotics we'll talk about are fluoroquinolones. They inhibit bacterial DNA topoisomerase 4 and DNA gyrase to prevent DNA supercoiling and promote DNA breakage. This leads to cell death within the bacteria. There's agents that are separated into respiratory fluoroquinolones that have coverage for strep pneumo and non-respiratory fluoroquinolones such as ciprofloxacin. All fluoroquinolones have black box warnings, including one for tendon inflammation and/or rupture. This is more likely in patients that have concurrent systemic steroid use, organ transplant patients, and patients that are 60 years or older. There's also a risk for peripheral neuropathy that can last for months or years after drug discontinuation. And lastly, there's also a black box warning for CNS side effects, including an increased risk of seizure. Adverse side effects of these medications include QTc prolongation, as well as increased photosensitivity while on the medication. For patient education, you want to educate them to separate these medications from polyvalent cations, such as calcium or iron, etc., by 2 to 4 hours. Also, fluoroquinolones can have an effect on blood glucose, so our diabetic patients will want to measure their blood glucose more frequently. The last antibiotic we'll talk about for bacterial rhinosinusitis is doxycycline. Doxycycline inhibits bacterial protein synthesis by reversibly binding to the 30S ribosomal unit. The side effects of doxycycline include nausea, vomiting, diarrhea, as well as increased photosensitivity. It's important to educate our patients on taking this medication with a full glass of water and to separate it from polyvalent cations by at least 2 hours. We'd like to avoid doxycycline in children less than 8 years old and pregnant and breastfeeding females due to the risk of doxycycline causing tooth discoloration in maturing teeth. Intranasal steroids are first-line agents for moderate to severe rhinitis. In this table, you can see the generic and brand names of the different intranasal steroids, as well as the dosing for adults and children. The most common side effects of intranasal steroids include headache, dry nose and nosebleeds, as well as unpleasant taste. It is important to educate patients that these medications may take up to 1 week for full effect. Budesonide is the preferred agent in pregnancy, as well as when they're using the medication, they want to point the tip away from the nasal septum. Decongestants may be helpful in patients that have severe nasal congestion. Systemic decongestants, such as phenylephrine and pseudoephedrine, may be reserved for patients that have more severe symptoms, whereas topical decongestants, such as Afrin, may be used in patients that have moderate symptoms and only require a few days of use. We want to avoid the use of decongestants in children less than 2 years old. For our oral systemic decongestants, we want to use caution in patients with cardiovascular disease, uncontrolled hypertension, since these agents can increase blood pressure, hyperthyroidism, because they can worsen hyperthyroidism, diabetes due to the increase in blood glucose, bowel obstruction, glaucoma due to the increase in intraocular pressure, BPH, since these agents can cause urinary retention, and in the elderly. We want to limit the use of intranasal decongestants to less than 3 days due to the fact of rebound congestion. The most common side effects of these agents include cardiovascular stimulation, CNS stimulation, as well as headache and dryness.
By the end of this presentation, I hope you'll be able to describe the proper administration technique for otic formulations and understand the mechanism of action, common side effects, dosing strategy, and patient education points for the following condition: otitis externa, otitis media, and cerumen impaction. First, let's begin with the basics of otic preparations.
The ear is divided into 3 regions. The external ear is composed of the pinna, ear canal, and tympanic membrane. The inner ear consists of 3 small bones with Latin names that roughly translates to the hammer, anvil, and stirrup. The middle ear is connected to the pharynx through the eustachian tube, which equilibrates air pressure across the tympanic membrane. The inner ear has 2 regions: the cochlea, which is responsible for hearing, and the vestibule, which is responsible for balance. Today's presentation will focus on conditions that affect the external and middle ear. Patients should be taught to properly administer otic medications since only about 40% of patients medicate appropriately. The proper instructions for otic preparations are listed here. Patients should also be instructed to minimize trauma to and avoid water exposure in the ear while an active infection is going on. When there is marked ear canal edema, a wick of compressed cellulose or ribbon gauze may be placed in the canal to facilitate otic administration. Wick placement permits eardrops to reach portions of the external auditory canal that are inaccessible because of canal swelling. As the canal responds to treatment and patency returns to the ear canal, the wick often falls out. When a parent or a caregiver has to administer eardrops to a child, it's important to have the child lay flat with the affected ear facing up on a pillow or stuffed animal. For the caregiver or parent to pull the ear backward and down to open the ear canal, and then to place the correct number of drops in the ear and continue the administration as appropriate. As a pharmacist, I often get asked whether or not ophthalmic preparations can be used in the ear or otic preparations can be used in the eye. What do you guys think? Which one's true and which one's false? Ophthalmic preparations have a neutral pH and therefore may be better tolerated than otic preparations, and therefore ophthalmic preparations can be used in the ear. However, otic preparations cannot be used in the eye due to the concern for pH, clarity, and etc. that's needed in eye drops. The first disease state we'll talk about today is otitis externa. Otitis externa is an acute, painful, inflammatory condition of the external canal that may extend from the pinna to the tympanic membrane. The rapid onset of ear canal inflammation leads to ear pain, itching, discharge, and canal edema and redness. Tenderness with movement of the tragus or pinna is a classic finding. Most common cases are from swimming or minor damage from inappropriate cleaning. Otitis externa can occur at any age and is the most common cause of doctor visits for ear pain. The infection can spread into surrounding soft tissue and bone if left untreated in some patients. Necrotizing otitis externa is a medical emergency that occurs more frequently in older adults with diabetes or immunocompromised patients. Otitis externa is caused by the breakdown of the protective epithelium barrier by abrasion, maceration, or fluid introduction. The 2 most common isolates are Pseudomonas and Staphylococcus species. However, about 1/3 of the cases are polymicrobial. Fungal pathogens, such as Candida and Aspergillus species, are common in tropical environments or in patients previously treated with antibiotics. Inflammatory skin conditions and allergic reactions can cause non-infectious otitis externa and can be chronic. Topical antimicrobials, including acetic acid, aminoglycosides, polymyxin B, and quinolones, are the treatment of choice for uncomplicated cases. Some formulations will also have corticosteroids, which may help resolve symptoms faster. However, there is little to no evidence suggesting one product is superior to another. Neomycin, polymyxin B, and hydrocortisone formulations are reasonable first-line therapy if the tympanic membrane is intact due to the effectiveness and low cost. Ofloxacin and ciprofloxacin dexamethasone can be used if the tympanic membrane is not intact or if it cannot be visualized, since they are approved for middle ear use. Oral antibiotics are reserved for infections that have spread beyond the ear canal or in rapidly progressing infections. Pain is a common symptom of otitis externa and can be very bothersome. Oral analgesics are the preferred treatment, including NSAIDs and Tylenol, depending on the patient. Benzocaine topical ear drops may decrease the effectiveness of the antibiotic and therefore should be avoided.
There are several ways to prevent otitis externa. For those that are worried about swimmer's ear specifically, there are isopropyl ear drops. 1 to 2 drops of rubbing alcohol can also be used. A mixture of 1 to 1 isopropyl alcohol to white vinegar and earplugs are all strategies used to prevent otitis externa, specifically in relation to preventing water from getting inside the ear canal and to aid in the drying of the water that may be in the ear canal. Now let's move on to otitis media. Otitis media is the acute onset of middle ear inflammation with symptoms very similar to otitis externa. It's common in children, with 80% of children having at least one episode of acute otitis media and 80 to 90% having at least one episode of otitis media with effusion before school age. Acute otitis media is usually a complication of a eustachian tube dysfunction following an acute upper respiratory infection caused by a virus. Infectious acute otitis media can be caused by bacteria in about 50 to 90% of the cases. Streptococcus pneumoniae, H. flu, and Moraxia catarrhalis are the most common organisms. Analgesics are recommended in all patients complaining of ear pain, fever, or irritability. Disrupted sleep is the most common symptom of why parents seek care. Therefore, analgesia around bedtime becomes particularly important. Ibuprofen is preferred since it has a less frequent dosing interval and is less likely to be toxic than acetaminophen. Reminder that ibuprofen can only be used over the counter for patients that are 6 months or older. The typical dose in pediatrics is 10 mg per kg every 6 to 8 hours with a max dose of 40 mg per kg per day. Topical benzocaine may also be helpful, which is a contrast to otitis externa. Antibiotics should be routinely prescribed for children with acute otitis media and severe symptoms, and for children that are less than 2 years old with bilateral otitis media. Severe symptoms include moderate or severe ear pain for at least 48 hours, or a temperature of 102.2 or higher. For other cases, observation before prescribing antibiotics is appropriate. A large prospective study found that 2 out of 3 children will recover without antibiotics. If observation is chosen, there must be a plan for the parents to follow up in 48 to 72 hours for persistent symptoms. This plan could be a scheduled follow-up visit or a backup antibiotic prescription to be filled only if symptoms persist. Persistent symptoms for 48 to 72 hours after treatment requires a repeat ear exam. If otitis media is present, you can initiate or change antibiotic therapy. If symptoms persist despite appropriate antibiotic therapy, consider intramuscular ceftriaxone, clindamycin, or trypanocentesis. As you can see here, amoxicillin or augmentin are the preferred agents in otitis media. The most common side effects of these antibiotics include GI upset with nausea, vomiting, and diarrhea. Giving or taking the antibiotic with food may decrease the amount of GI upset, and it's important to educate the patients to complete the full course of antibiotics. It is important to note that otitis media with effusion does not warrant antibiotic use, as they do not hasten the clearance of middle ear fluid. The last condition we'll be talking about today is cerumen impaction.
Cerumen is a mixture of fatty secretions of the sebaceous and sweat glands with dead skin and other debris. Typically, these secretions are propelled by jaw movement of the canal to the opening where they dry up and flake off. Earwax that sits in the canal for an extended period of time or picks up excess debris will become dry and hard and can cause a blockage. Cerumen impaction is present in about 10% of children, 5% of normal healthy adults, and up to 57% of older adults in nursing homes. Increased incidence occurs in those with an anatomic deformity, those with an increased number of hairs in the external auditory canal, or those with a physical barrier in the ear canal, such as a cotton swab, hearing aid, or earplug. Treatment options include watchful waiting, manual removal, the use of a cerumen-olynic, or irrigation. Referral to a specialist for further evaluation is indicated if treatment with a cerumen-olytic agent followed by irrigation is ineffective, if manual removal is not possible, if the patient develops severe pain or has vertigo during irrigation, or if hearing loss is still present after cerumen has been removed. The use of cotton swabs and ear candles should be avoided. There are 3 types of cerumen softening preparations: water-based, oil-based, and non-water, non-oil-based. Water-based and non-water, non-oil-based agents increase cerumen miscibility, whereas oil-based preparations lubricate the wax. All of these agents should not be used in patients with tympanic membrane perforation. Once the cerumen is softened, the ear canal can be irrigated with warm water or saline if the patient still has symptoms. Sometimes the cerumen-olynic may cause the earwax to soften and be able to propel itself along the ear canal. In conclusion, proper administration of otic preparations is key for medication effectiveness. Otitis externa and otitis media have different treatment routes, and cerumen-olynics can help with cerumen removal. If you'd like more information about the things talked about in today's presentation, please see these resources.
By the end of this presentation, I hope you'll be able to describe the proper administration technique for eye drops, ointments, and gels, including nasolacrimal occlusion and tips for administration to children. I also hope that you would be able to understand the mechanism of action, common side effects, dosing strategy, and patient education points for the agents in the following conditions: conjunctivitis, dry red eyes, and glaucoma. The eye is a hollow sphere composed of 3 layers of tissue. The fibrinous tunic includes the sclera, which is the white of our eyes, and the clear cornea, which covers the anterior tip of the eye to allow light to pass through. The vascular tunic includes the vascularized connective tissue and the iris, which is the colored part of the eye that's smooth muscle, and is responsible for opening and closing the pupil in response to light. And lastly is the neural tunic, which is also known as the retina, and it contains the nervous tissue responsible for photoreception. There are also 2 cavities located within the eye: the anterior cavity, which has the aqueous humor, and posterior cavity, which has the vitreous humor. In order for an eye drop to be safe and effective in the eye, there are several different properties that this eye drop must have. It must be sterile and free of foreign particles. It has to contain a suitable preservative but it needs to be free from irritating effect. It also needs to be isotonic with the lacrimal secretion and chemically stable. Lastly, a drop volume can only equal around 50 microliters. The normal volume of a tear is around 7 microliters, and the whole eye can hold up to 30 microliters of liquid without spillage. This is important to keep in mind when we're educating our patients on proper administration technique.
In order to achieve the previous properties of an eye drop, there are some common ingredients. First and foremost, there's always a drug or an active ingredient within the product. There's also several different types of preservatives that can be used. There's surfactants, which can help to improve solution clarity, pH buffers and adjusters, tonicity agents, and viscosity agents. I'd like you to focus on recognizing the agents in blue as preservatives. Preservatives can be irritating for some patients, and often a patient will not be able to tolerate one preservative but can tolerate another. Therefore, simply switching from one product to another within the same drug class may help out with side effects and keep efficacy due to the differences in preservatives. There are many ophthalmic dosage forms on market today. There are liquids, semi-solids, solids, and intraocular forms. The preparations we'll be focusing on today are in the liquids and semi-solids categories. Another way that ophthalmic dosage forms are categorized are either by solution, suspension, or emulsion. You can see the different advantages and disadvantages of each of these types. It is important to educate our patients on proper eye drop administration, not only for efficacy but also to help reduce complications such as infection. Many patients will want to touch the tip of the bottle to their eye directly. This increases their risk of infection and therefore should be educated against doing that. You can see all 10 steps of proper eye drop administration listed here. It's important to note that when a patient is administering multiple medications or multiple drops, they'll need to wait at least 5 to 10 minutes between the medications. This is because the capacity of the eye is really only for about one drop at a time. For contact lens wearers, they need to wait at least 15 minutes before inserting contacts after the administration of an eye drop. Another important education point to make during the proper administration of eye drops is nasolacrimal occlusion. Our lacrimal glands secrete tears to wash away foreign bodies, but also to moisten the cornea and prevent dry eye. Nasolacrimal drainage allows for a pathway for systemic absorption of ophthalmic agents. Therefore, nasolacrimal occlusion and eyelid closures decreases systemic absorption by about 60% and also increases the bioavailability of the drug, leading to better efficacy and fewer side effects. In order to do this, you just instruct the patient to close their eyelid and apply pressure to their nasolacrimal duct for at least 2 minutes, which is on the inner corner of the eye near the nose. For the parents administering these eye drops to their children, there are a couple tips and tricks in order for proper administration. First is to have the child lay down on their back with their head on a pillow or a plush toy for comfort. Secondly, if the child resists the eye being touched due to pain or discomfort, they can have the child lay down and close their eyes. The parent can then place the eye drop on the corner of the closed eye near the bridge of the nose and then have the child open their eyes. This allows the drop to fall in naturally from the corner of the eye into the eye itself. There are a couple of differences when a patient is administering an eye ointment or gel versus an eye drop. First, the patient will need to pull down the lower lid to form a pocket, and then instead of placing a drop into their eye, they will squeeze a ribbon into the pocket and then blink gently and close their eyes for 1 to 2 minutes.
The first disease state we'll talk about today is conjunctivitis. Conjunctivitis is the inflammation of a thin, transparent layer of tissue that lines the inner surface of the eyelid and the sclera. It's a very common disease state with around 4 million cases per year. Common symptoms include pink or red sclera, itching and burning, ocular discharge with complaints that eyelids are stuck together in the morning, feeling of a foreign body in the eye or fullness around the eye. Pain, increased light sensitivity, and blurred vision are rare with uncomplicated conjunctivitis. If a patient is complaining of these symptoms, conjunctivitis is unlikely, and the patient should be referred to an eye specialist. There are 3 main causes of conjunctivitis: allergic, infectious, and chemical. Today we will only focus on the treatment for allergic and infectious.
there are some major differences in symptomatology between the causes of conjunctivitis, and they are listed in bold. As you can see, the bacterial conjunctivitis is usually unilateral with purulent discharge, whereas allergic conjunctivitis is bilateral with watery discharge and lots of itching. Viral conjunctivitis is more common in adults, and adenovirus is particularly contagious. 15% of cases of conjunctivitis are bacterial, whereas 50 to 75% of pediatric cases are bacterial. Children 3 months to 8 years are more likely to have infections caused by staph, strep, or H-flu. And gonorrhea or chlamydia are likely in sexually active teens and adults. Bacterial and viral conjunctivitis can be highly contagious, and patients may be contagious for up to 48 hours before symptoms are present. Bacterial conjunctivitis is usually self-limiting and will resolve within 1 to 2 weeks, but antibiotics shorten the length of infection and reduce the person-to-person spread. In fact, most schools will require treatment before a child can return to class. The patient will need to stay home for at least 24 hours after discharge from the eye is seen, or 24 hours after starting antibiotics. Empiric antibiotic treatment is broad spectrum and focused on staph coverage. Tobramycin and gentamicin are reserved for more serious infections, and fluoroquinolones are typically last line due to their poor strep coverage and high cost. Fluoroquinolones cannot be used in children less than 1 year old. If there are no improvement on one of these first-line or second-line agents, referral to an eye care specialist may be necessary. In the United States, there are 4 classes of ophthalmic antibiotics currently available. However, no clinical differences in the efficacy of these antibiotics has been discovered. As a quick review, bacteriostatic means that the antibiotic prevents the bacteria from further growth, but relies on the body's natural immune response to clear the infection, whereas bactericidal means that the antibiotic will actively kill the bacteria. There are increasing resistance to older generation antibiotics, and therefore there has been a shift towards fluoroquinolone use. If a fluoroquinolone is prescribed as a second-line agent, symptoms should improve within 3 days of initiation. If there is no symptom improvement in that time, then referral to a specialist is warranted. Viral conjunctivitis is self-limiting and typically resolves within 5 to 14 days. Antibiotics should be avoided and do not improve patient outcomes. Treatment instead is focused on the patient's symptoms. Lubricants can be used to reduce the gritty feeling or the sensation of a foreign body in the eye. Symptoms similar to an allergic reaction may occur due to the preservative in the product. There will be a slide later that shows each product with the different preservatives. Cool compresses may be used to negate any pain or warmth. Since viral and bacterial conjunctivitis are highly contagious, it's important to educate our patients on transmission reduction. They can reduce the transmission of this infection by washing their hands often and avoiding touching the eye, using separate hand towels, avoiding contact lens use, and discarding any eye makeup that was used prior to the infection. It's important that they continue these techniques for even days after initiation of treatment due to the fact that bacteria is still active for 48 hours after treatment initiation, and the virus is still contagious for up to 14 days after initiation of treatment. Allergic conjunctivitis is inflammation in response to an allergen, causing mast cell degranulation and inflammatory mediator release, including histamine. First-line treatment includes over-the-counter antihistamine and vasoconstrictor agents. Vasoconstrictors are inexpensive, over-the-counter, and therefore first-line. However, these agents should only be used in short-term or episodic cases. Second-generation topical histamine H1 receptor antagonists are second-line. Antihistamines are more effective than the vasoconstrictors, but can be more expensive. Antihistamines with mast cell stabilizing properties are preferred agent for long-term use. For recurrent or persistent allergic conjunctivitis, mast cell stabilizers can be used as a third-line agent. If symptoms are not adequately controlled, a brief course of low-potency and low-frequency topical steroids may be used. Topical NSAIDs, such as ketorolac, have also been approved for the use of seasonal allergic conjunctivitis, but are generally used as adjunctive agents. At this point, referral to a specialist would be indicated. Oral antihistamines can be used especially if the patient is experiencing additional systemic effects. Some additional measures can also be used as adjunctive measures to improve symptom management and are as follows: artificial tears to dilute allergens, cool compresses or ice packs, avoidance of allergens, frequent clothes washing, as well as bathing or showering before bed.
Antihistamines can target one or more histamine receptor types. The effects they exhibit vary depending on their targeted histamine receptor type. All histamine receptors are targeted by the ocular antihistamines and have immunomodulatory effects. However, some agents are more selective for one antihistamine receptor over another. Blockade of the H1 histamine receptors reduces swelling, itching, erythema, and pain. Blockage of the H2 receptors reduces erythema and causes vasodilation. Blocking H3 receptors affects nasocongestion, and H4 receptor block reduces itching and swelling. These agents can exhibit efficacy within 20 minutes of application. Drugs that have the combined mechanism of action of intraocular antihistamines and mast cell stabilizers have shown the most efficacy in allergic conjunctivitis and are preferred treatment agents. Mast cell stabilizers inhibit the degranulation of mast cells and prevent histamine release. Ocular mast cell stabilizers have moderate efficacy when compared to ocular antihistamines with or without mast cell stabilization properties. Full efficacy is reached in 5 to 14 days after therapy has been initiated, and therefore these medications are not useful for acute symptoms. These agents may be used for up to 3 months. Drops are instilled in both eyes, and patient compliance may be limited by the frequent dosing of these agents, which must be given up to 4 times a day.
Ocular vasoconstrictors provide temporary relief of ocular redness. Their typical dose is 1 to 2 drops up to 4 times a day as needed. Side effects include rebound congestion, and therefore these agents should not be used for more than 3 days due to this rebound redness. Can also cause pupillary dilation and tingling in the eye. Oxymetazoline has been discontinued from market, and nefazolin is contraindicated in narrow-angle glaucoma. Keratoconjunctivitis, or SICA, is also known as dry eye syndrome, and it is a bilateral disruption of tear film that leads to inflammation. These patients are at increased risk of blinding infections. The cause is either decreased tear production, increased tear evaporation, or an abnormality in the production of mucus or lipids in the tear layer. Risk factors include the elderly, females, smokers, those patients with an inflammatory condition such as allergies, asthma, collagen vascular disease, patients with autoimmune disorders such as RA, lupus, colitis, or Bell's palsy, environmental factors including wind, reduced humidity, cigarette smoke, air conditioning, air travel, prolonged visual efforts, especially towards the end of the day, and medications, including antihistamines, diuretics, anticholinergic, antidepressants, statins, systemic retinoids, and isotretinoin. In addition to environmental controls and treating underlying conditions, the only medical treatment out there for occasional dryness is artificial tears. For more frequent or severe symptoms, patients should be referred to a specialist, and the specialist may prescribe the following agents. Cyclosporin increases aqueous tear formation and decreases ocular irritation by preventing T cells from releasing cytokines that would incite inflammatory responses. The side effects of Restasis includes burning, discharge, itching, and blurred vision, and it's contraindicated in active ocular infections. Lifitegrast binds to integrin lymphocyte function associated antigen 1, LFA1, and blocks the interaction of LFA1 with its cognitive ligand intercellular adhesion molecule 1, or ICAM1. It can cause eye irritation, blurred vision, as well as unusual taste sensation. And the last line agent for patients referred to specialists include punctal plugs. There are a variety of lubricating eye drops and ointments on the market with a multitude of preservatives. The most irritating preservative on market is benzalkonium chloride, or BAK. Here are the products that contain BAK. As you can see, Clear Eye and Visine products often contain BAK. If a patient experiences irritation from one lubricating product, recommend switching to a different brand since most of the brands use the same preservative across their entire product line. You can also recommend the patient to switch to a preservative-free product that comes in single-dose vials. However, these preservative-free options tend to be much more expensive. Something else to keep in mind is that many of the OTC artificial tear products contain other active ingredients. For example, some of the Visine products contain vasoconstrictors to relieve the redness. Since we don't want patients to chronically use ophthalmic vasoconstrictors, we'll want to educate them about multi-ingredient products. Lastly, if a patient complains that their artificial teardrop doesn't last long enough, then you can recommend them to switch to a lipophilic product. The more lipophilic products are thicker and their fit tends to last longer. However, the thicker products may also cause temporary blurry vision. Gels and ointments are great to recommend for our patients to use for overnight relief. The last disease state we'll talk about today is glaucoma. Glaucoma is caused by irreversible damage to the optic nerve and retinal ganglion cells that leads to bilateral loss of visual sensitivity and field of vision. It's usually unnoticed until it has gone too far, and is the second leading cause of blindness in America, being the leading cause of blindness among African Americans. There are several types of glaucoma. Primary open-angle glaucoma, or POAG, is what we will focus on today, and it is 70% of glaucoma cases. Acute close-angle glaucoma is caused by a mechanical blockage of the trabecular meshwork by the iris and is a medical emergency. Any patient that has visual loss must be referred to a specialist. Primary open-angle glaucoma is caused by a decrease in aqueous humor outflow that leads to optic neuropathy. Incidence of POAG increases with elevated intraocular pressure. However, the patient does not have to have increased IOP in order to have glaucoma. Risk factors include age, African American race, family history, and diabetes. Ophthalmic corticosteroids can exacerbate POAG. The agents used in primary open-angle glaucoma treatment either decrease aqueous humor production or increase aqueous humor outflow.
Prostaglandin analogs are the most frequently prescribed initial eye drops for lowering intraocular pressure in patients with glaucoma because they are the most efficacious, well-tolerated, and instilled only once daily. Therefore, they are often considered as the initial medical therapy unless otherwise contraindicated. Other agents include beta blockers, alpha-2 adrenergic agonists, parasympathomimetics, and topical carbonic anhydrase inhibitors.
Prostaglandin analogs increase uvoscleral and/or trabecular outflow and decrease intraocular pressure by 25 to 33%. There are several potential side effects of these agents, including irreversible iris pigmentation that happens in people that have mixed color irises and causes them to turn brown. This discoloration is worse with latanoprost. There are several contraindications as well. There is one DDI, or drug-drug interaction, with thimerosal that can cause precipitation if the agents are given concurrently. Therefore, the agents must be separated by at least 5 minutes. These agents are given at bedtime once daily. If the patient takes these agents more than once daily, it decreases the agent's ability to lower intraocular pressure. Ophthalmic beta blockers cause blockade of beta 1 and beta 2 receptors to cause a decrease in aqueous humor production. This leads to a decrease in intraocular pressure by 20 to 25%. Keep in mind, all of these agents can be absorbed systemically, and therefore they're contraindicated in asthma, COPD, AV block, sinus bradycardia, and overt cardiac failure, especially non-selective agents. Drug-drug interactions include additive beta blockade effects with systemic beta blockers. Generally, all of the beta blockers are given twice daily. Beta-taxolol is the best tolerated because it is most beta-1 receptor specific, and therefore is best for patients with COPD or asthma. Refer to your textbook for an extended product list, as I've only included 2 agents here. Ophthalmic alpha-2 agonists decrease aqueous humor production. Non-selective agents, just meaning alpha agonists, can improve aqueous outflow. These agents decrease intraocular pressure by 20 to 25%. These agents are contraindicated with use of MOAIs, and there's also a drug-drug interaction for an additive decrease in pulse with other bradycardia-causing agents. I've listed the alpha-2 selective agonists here, including its agent by itself and in a combination. Ophthalmic carbonic anhydrase inhibitors decrease aqueous humor production and decrease intraocular pressure by 15 to 20%. They are contraindicated in patients with sulfonamide allergies, and use is not recommended in patients with severe renal impairment. Systemic carbonic anhydrase inhibitors, such as acetazolamide, are very effective in reducing intraocular pressure by 20 to 30%, but cause paresthesia, GI disturbances, CNS effects, and electrolyte disturbances. Therefore, topical agents are preferred over systemic agents. There is a drug-drug interaction if used with high-dose salicylates that can cause acidosis. This is a theoretical interaction and not seen clinically. The ophthalmic carbonic anhydrase inhibitors are listed here as single agents and the one agent that's in a combination. Ophthalmic cholinergic agonists increase trabecular outflow and decrease intraocular pressure by 20 to 25%. One of their potential side effects includes increased miosis that leads to decreased night vision. Their use is limited due to frequent dosing intervals and local side effects. However, there are no reported drug-drug interactions. The most commonly used ophthalmic cholinergic agonist is listed here. The last product I'd like to talk to you about today is Latisse, or bimatoprost. This is the same active ingredient as the drug in Lumigan. It is used to thicken and lengthen eyelashes, which is the side effect of all the prostaglandin analogs. You can see the dosing repeated here. It's important to note that the effect disappears with drug discontinuation, and therefore this medication must be used continuously in order for sustained effects.
In conclusion, proper administration of ophthalmic preparations is key. Bacterial, viral, and allergic conjunctivitis all have different treatment approaches. An appropriate treatment of glaucoma is important to prevent further damage and blindness. If you would like further information on any of the things seen in this presentation, please refer to these references.